Hi, good morning, everyone. Very good morning to everyone here. We are about to start our sessions. My name is Dr. Vibha Jain. I'm from India, and it's my pleasure to have you all, the esteemed guests, at the event hosted by UCG Conferences. We had some amazing sessions in the last 2 days, where we heard many practitioners, doctors, clinicians, pharmacists, nursing professionals, I mean, sharing their experiences and sharing all kind of things from their clinical practices to the modern technology, which is on all there. We had an amazing lineup over there, and we look forward to an amazing sessions in the day 3 as well. A bit about myself: I am a general practitioner. I practiced for around a decade, and then I switched over to healthcare IT. Have been doing all kind of stuff in EMR, EHRs, and exploring new technologies. So again, I welcome you all to the day 3 of this particular event. Look forward to some amazing discussions today as well. The time is like 25 minutes for each of the speaker. We would request the speakers to abide by that time, and we'll be happy to take the questions anyone would have after the session gets completed. So I would now like to begin the day 3 session. Our first speaker of day 3 is Ms. Rua Aman from KSA, and I'm passing her the stage to deliver the speech on factors affecting the development of clinical nurses' competence. Ms. Rua, I hope I have pronounced your name correctly.
Yes, good morning. How are you? Thank you for this introducing, and good morning for all. And this morning, I'm waiting to put it my slide, or from your sides you will go in. I will, inshallah. And thanks for all the speaker for these 2 days. It was very informative and knowledge we taking, and thanks for UCG for this conference. Just 1 minute, I will put my slide.
Any assistance you would need, Ms. Saman?
Good morning.
Ms. Saman, you would like to mute one of the speakers, I think. If you've joined from two devices, it will help you.
It is okay now?
Yes, it's nice now. Okay. There's no echo now. So I think we are able to hear you as well as see your slides, and you may start.
Okay, can I start now?
Yes, please.
Good morning for all. My name is Roa Aman. From Saudi Arabia, I am Master Healthcare degree. I am working in Irada Hospital for psychiatric and addiction patient, and I'm working healthcare master degree. I'm working as a nursing education. I have my experience in many departments as we are nurses from the clinical to until we working in critical care area. After that, I'm working as psychiatric also patient inpatient. After that, as a nursing education, and now also with the research unit and as a clinical instructor for the student and our new nurse. Today, I will going to talk about the factor affecting the development of a clinical nurse's competency. As we know the competent nurse, it is the backbone of healthcare of the hospital. This hour in the cluster, the value about the innovation, empowerment, efficiency, and accountability, our mission to be deliver prevent, accessible, integrated care through a safe, suitable, and balanced system, resulting in improving primary care and enabling people to take ownership of their own health. And our vision in the cluster to transform into a world-class healthcare provide for a comprehensive human interest care. And from there, we as the nurses all the time, we try to be the best caring and the quality of caring. And about this study, or my title today, about how it is nursing plays a vital role in ensuring the quality of healthcare service. The implementation of these services should adhere to the ethical code of nursing and the career leader of competence. Competence encompasses the knowledge, skill, attitude, and ability nurses must possess to effectively perform their duties and deliver high-quality care to patients. The nursing competency framework covers 4 essential skills: comprehending requirement, delivering healthcare, fostering team working, and facilitating informed decision making. These abilities are interconnected and applicable in various nursing practice settings. The competent nurse in different journey in her career, it will be effective in each point she be in that position. As we see here in this diagram, motivating and train. It is a humanistic practice and management and leadership competency, clinical nursing competency, and professional development competency. Each competent in each of these one, it will be going to be more responsible, more effective, more professional in her practice. Clinical competency include the principle of nursing care, adhere to clinical guideline and effective nursing intervention. It is also encompassed that utilization of technical and communication skill, knowledge, clinical reason, and emotion and value in a clinical setting. Define the clinical competency as Nibas. He defined that clinical competency as an amalgamation of knowledge, skill, and attitude, elegant, harmoniously with those required during fieldwork phase, as essential members of healthcare system. Nurse bear the critical responsibility of maintaining clinical competency. The impact of nursing competence extends beyond the patient and encompasses the well-being nurses themselves. Competent nurse contributed to patient safety, and prioritizing clinical competence enables nursing to deliver high-quality care, and it was found that higher level of clinical competence is positively correlated with variables such as empathizing with colleagues and patients. Self-efficiency, job specification, all that what we can see in that competence. The ongoing process competency assessment evaluated, track, and enhance the competence of healthcare professional. Currently, three measurement skills have been developed to assess critical care nursing competency, the critical care competency assessment instrument in self-assessment competence tool, and the intensive and critical care nursing competency skill. This study done to sanitize it and analyze the literature on nursing clinical competence to assess the factor affecting nursing clinical competence. As we know, nursing competence, it is clinical competence, routine care, emergency care, care according to patient need, care of non-coronary patient, professional competence, that means personal development, teamwork, professional ethics, efficiency of nursing education. This study design systemic review. The method about this done by the group of researchers, and we done, and this study utilized an extensive literature search of online database, including Scopes, Webs of Science, and PubMed. This review fell with the guideline provided by the effective practice and organization of care. Coherence group and the preferred reporting items for systemic review and meta-analysis statement. A systemic review was conducted following the guideline provided by the Coherence Effective Practice and Organization of Care. And the preferred reporting item system reviewing and meta-analysis statement. The review adhered to premise BRISMA checklist heading for the section, including eligible criteria, information source, and search strategy and study selection. After this study finding, a total of 6,273 nurses participant in the 20 study, including in this review, these including 18 cross-sectional study and 2 descriptive correlation studies, all of which employed quantitative research methodologies. And this included the study were conducted in Saudi Arabia and Finland and Iran, Japan, South Korea, and Sudan and Finland. The details of this practice included study are presented in. The result for this study that analyzes revealed several key factors that significantly affected nurse clinical competence. As we see in this one diagram also, we have many factors, and that these factors including years of experience, workplace environment, theoretical knowledge and educational level, material status, clinical training, job specification, turnover intonation, job stress, and critical thinking. All these, it is affected in nursing clinical competency. Discussion enhancing client outcome relies heavily in the clinical competency of healthcare professional. For nurses who constitute significant portion of the healthcare workforce, this is especially critical in the term of making complex decision and delegation of care. Given their pivotal role in a global healthcare system, it is important to ensure that the nurses are adequately trained and possess the necessary competence to deliver safe and high quality of healthcare. In the end of this study and this conclusion of this study, we see how it is understanding and addressing these factors are critical for enhancing nursing clinical competence and ultimately to improving patient outcome. Further research and intervention should be directed toward promoting support work and also supportive work environment, continuous education, and the development of critical thinking skills among nurses to optimize their clinical competence. Thank you. Any question? Back to you.
Thank you so much, Dr. Noah, for a very informative session you had. I would now request the members for any questions they would have. We'll be happy to take those questions. So, Mishra, I mean, before anyone asks, I actually have a question for you in the sense, like, I would here to learn, I mean, it would be good to know, I mean, these competency frameworks and the things which you've told, how you've implemented in your hospital and what's the benefit you've got out of it when you implemented at your own center. So what's that which has like one thing which impressed you most and which come out very beautifully when you started off?
Thank you. Thank you for this question. We have in our cluster, we have a MUDEBI, a severe competency that each quarter year in the year, we added some general competency, and we are as a psychiatric nurse, we have special competency for our work. And during we give them the self-study. After that, if there is any, we see a degree, it is enough because there is also checklist and also the exam test. And after that, we can see and we go for them in the unit and we see what is the difficulties for them as a knowledge, as even the attitude and how it is improvement for them. And we try all the time, at least we have a planning in the year 3 times to giving all these courses and competent to be more competent in this competency.
That's very nice to hear. I think there's one question from our audience. The goals under the framework, are they short-term or long-term goals set by the teacher?
Sorry?
The one question which our audience has asked is, the goals under the framework, are they short-term goals or are they long-term goals set by the teacher?
Both. We have a short goals and we have a long goals, and all the time we have this one. It will be with him as a test, and he can also try to that, because as I said for you, we have a general competency and a specific specialized competency. And during the cases coming for us, and we can sometimes added more competency to be achieved all the any cases it will be coming, and how the knowledge it will be more improvement as skills and attitude, and especially with the communicated with this kind of psychiatric patient and addiction patient.
Thank you. I hope that answers your question, Mr. Shimon. There is another one which asks us, should a nurse fail the competency component, what is the next step which is implemented?
What should?
So
Sorry?
if there is a competency framework deployed for nursing, and if someone falls short of it, someone fails that competency framework, what is the next step which is implemented? I mean, do we work on that nurse to improve it, or how do we handle that situation?
Yes, we will going to work with that one to more and more. We have all the time, and it will be our goal to be him, let him to improve. We sit with him and we see what is the difficulties as a knowledge or as attitude or as a school. You know, we have that checklist, and we give him more times until he is improvement. And we all the time implemented him. He is in the good situation, and he competent in this one competency. And
Great.
all the time are with them, until, because this our goal to be lead them to competent. This our nurses, they will giving the caring, it is more quality of care. That means the effective for our hospital. We have a good caring because from this nurse, and for that we are all the time be sure we don't take be away from our nurses until they are competent. And this one yearly done,
This is a very supportive environment which you are creating for your nursing staff, because once you've created the benchmark, if somebody is not able to achieve that, you're making them, creating an atmosphere, providing them with required tools, support, so that they can come up to that level where they're competent enough for with other peers in their industry. So we have one more question from Dr. Carlo. Are you willing to share the competency statements with the audience, or should we connect one-to-one with you, Ms. Rua?
Yeah, please contact with me. You want the competency?
That's what Dr. Carlo is wanting to have. Maybe you can connect with him one-to-one and then share the frame statements and all those things with him. And there's one more question, I think. Siobhan, it would be good if you can connect with Ms. Rua separately also, because you seem to have too many questions for her. One last question I'm taking for this session is, did the study reveal the level of attitudes of the nurses as one being receptive to learning? I mean, were they more inclined towards learning? Were they keen to improve themselves? Is this something which came out of the study which you did?
I didn't understand what the meaning of them. Sorry.
The question the person is asking is, did the study reveal the level of attitudes of the nurses as one being receptive to learning? Were they receptive to learning? Were they keen to learn things, or in their behavior? I mean, when you implemented this competency framework, the nurses, were they keen to learn from it, or when they were not very much inclined to learn it, or they were not ready to take it up? What was their behavior like?
Yes. This, as you know, this one systemic review, this study. But as my experience with my colleagues, and some of them not will be first when we start this one, Musabi Elsevier system, it was, we have these difficulties, to be learned, to be moved, and that one target from your job to be more quality and more caring, and But after that, when they see, we sit with them as one and one. When we sit it like that one, and we see how it is changed to be ability to be accept more and to be try to also improve himself. And after that, we see that how it be more confident for him when he know how he is working as a competent nurse and know all the criteria and the knowledge. And
Thank you
also
so
how
much. Thank you so
Thanks.
much for a very nice, informative session and answering all the questions we had. One kind of information to the audience as well. Once the session is completed, you can you can enable your mic and you can ask the questions yourself, because I think when I interpret the question, the thing which you might want to ask might get lost. So you can ask the questions yourself. Thank you so much, Ms. Rua. Thanks a lot for the session. May I now request our second speaker of the day, Dr. Sana from Egypt. I'm passing her the stage to deliver the speech on gum recession of natural teeth. Dr. Sana.
Good morning.
Good morning.
I'm Dr. Sana Fark from Iraq, not Egypt.
Okay, I'm so sorry for that, Dr. Sana.
Yeah, I'm from Iraq. I'm a periodontist from Baghdad. I have my own clinic, the Gum Health Clinic. I'm a lecturer at one of the universities in Iraq, Dentistry College. A continual medical education director at one of the hospitals in Baghdad for 8 years. I have many participations in many conferences and gave a lot of lectures about the topics of periodontology, different topics of periodontology. Today, let me show you one of the interesting topics that we as a periodontist trying to focus on. It's very interesting. Is it clear for you now?
Yes, it's clear. It's clear, Dr. Sana.
As a periodontist, one of the challenging cases came to the clinic is the gum recession, especially at the natural teeth. When they are at the smiling line, when they compromise the aesthetic considerations of the patient. Most of the patients came with different complainings, just like having teeth sensitivity, functional disability, or something, or the most important one is the aesthetic part. The scope of my session for today is, can I, as a periodontist, can I promise my patient with full root coverage? Can I reestablish the normal and the aesthetic view of his teeth? Let us start with the definition of gum recession. What does it mean? Gum recession is the apical or the apical recession or apical receding of the gum tissues towards the apex of the roots. So there will be an exposure of the root surface. Now, as you see in this picture, the teeth seem to be longer than they are actually. Also, the patient will suffer from teeth sensitivity. He cannot eat or drink something cold or something hot. Sometimes even speaking can be affected by the sensitivity of his teeth. So he came to our clinic. We are, as a periodontist, starting to look for the possible treatment. But before, we have to focus or identify the etiological factors. What causes this recession? Many factors interplayed to made this recession. One of them is the anatomical factor of the in the oral present in the oral cavity. We have a thin gingival biotype. His gingiva is very thin. It can show or display the underlying structures, especially the bone. So this will make the tissues are prone to trauma from a vigorous tooth brushing, just like if you see here as a traumatic factors, a vigorous tooth brushing, or using the polishing, the commercial polishing paste and powders present at the pharmacies. Also, we have the abnormal tooth positioning. Some people have procline teeth towards the buccal area. We say buccal, which faces the lips, or lingually, inclined lingually toward the tongue. Or sometimes the teeth are rotated in the position, so it makes it more prone to have a gum recession. Also, sometimes we have a high frenal attachment, the frenum, the raphe that can hold the lip with the gingiva, can pull the gingiva downward, so it will cause a gum recession. Also, we have a pathological factors such as the periodontal diseases, untreated periodontal diseases like gingivitis. Severe cases of gingivitis can advance to periodontitis, which is the destruction of the periodontium, gingiva, and the underlying bone. It's a very destructive factors. And sometimes, after the patient has aligned his teeth with an orthodontic appliance, he or she will suffer from gum recession. Unfortunately, sometimes when someone doing a big restoration with interproximal, what I mean by interproximal, the space between teeth, we call it an interproximal space. When the filling extended beyond the gingival line and at this area, there will be a gum recession and pocket formation at this place. During the last 4 years, we were depending on the Miller classification in classifying the recession type so that we can plot the treatment plan. This classification was depend on the height of available soft and hard tissue left after the recession has developed. And these are the 4 types or classes of Miller classification. We have a class 1, which we have a small distance of recession. Tissues are intact, still intact. Okay, as you see here. I don't know if we have a dentist watching us today. Class 2, there will be a deeper extension of the recession, but still we have a periodontium, nice periodontium, especially at the interdental area. Class 3 and class 4, there will be more destruction. There will be bone destruction also underneath the receded gums, which will extend to the to include the interdental area as well. The more the classes will be developed, class 1, we have a good result on treatment. We can promise the patient 100% or complete root coverage. But when it is class 2, there will be diminished percent. When we have a class 3 and class 4, we cannot promise him a full root coverage because the complexity of the situation. Many modalities we were making through or implementing, sorry, for these last years. We have the main 2 categories. We have the pedicle soft tissue graft procedures and free soft tissue graft procedures. Either we transform the tissues without excising them, just made a rotation to cover the recession, or advancing the tissues to cover the recession, or by combining them with a free gingival, with a connective tissue graft, putting underneath the flaps and cover them. We can implementing them as a one method, or combining them. Each one of these modalities benefits a special type of recession depending on the available tissues we have, according to, again, according to Miller classification. But these systematic reviews reveal that the best ways to cover the exposed roots by doing subepithelial connective tissue grafts taken from the pellet of the same patient with coronally advanced flap. We can do it alone, or by adding more regenerative or many biomaterials, just like we have nowadays, the mucoderm. We can put it instead of the doing another site or another surgical site for the patient at the same time, taking the graft from his pellet. We can substitute it with mucoderm xenotype. These two methods had showed improvement in the outcome of the width of the teeth. As we said, that one of the factors that made the gums recede is the quality of the tissues when we have a thin keratinized tissue or thin gingiva. When we increase the width of this gingiva or this tissue, we can prevent the future recession of the gingiva. Also, we can gain much more coverage of the tissues of the roots with years. Okay, and this diagram can show a review of the results I have found in many systematic reviews. As you see here, I look for the specific coronally advanced flap and addition of connective tissue graft. For class 1, we can see full root coverage, nearly 88% of the single tooth recession. And when we have multiple teeth recessions, we can achieve nice percent of coverage. Also, for advanced class, we have class 2. We have a nice, I know it's partial coverage, but it's a good percent when we have 78 to 86% of teeth have been covered. Very nice results. Also, for the multiple recessions, when we have multiple teeth have been receded, when we use the connective tissue, we can achieve 96% of the teeth can be covered. Okay, with a 63% of roots could be completely covered. Nice results. Also, we have the class 3, about the same results, but for root coverage, for complete root coverage, I cannot promise the patient for full coverage. Only 50% of the cases have been covered. And for the class 4 cases, they are still challenging cases. I cannot promise my patient. Okay. On implementing these surgeries and getting the results, we have invented another type of procedures, which called the tunneling technique, by preserving the interdental papilla without incising them to reflect a flap. We can preserve it just doing a tunnel, and then we can introduce our connective tissue through this tunnel and elevate the gingiva to cover the root. They were very nicely non-invasive techniques used during the last 20 years. Very nice results we got through them. We can use many xenotype grafts instead of the connective tissue graft taken from the same patient. We have good marginal tissue coverage of the grafted material. These are very important factors. Also, we will preserve the blood vessel supplying the area of the surgery. So it was a very nice innovation, and the results were very nice, as you see here in this summary or this table. We got a very nice and a high % of root coverage. Okay. But on depending on the Miller classification, we have faced many doubts. The main doubt was, when I have class 1 and class 2, both are there, the recession of the teeth not exceeding the mucogingival line, not exceeding the lower limit of the gingiva we see in the mirror. So to what extent we can consider it a complementary factor when we can achieve a nice result of coverage. Also, the second doubt was the class 3 and class 4 classification. Both have an interdental clinical attachment loss, but how can we differentiate them? Is there a limit that separates, or a threshold that name this recession as a class 3 or this one is a class 4 when we have a difficulty in achieving the procedures? This was a very tricky one. Also, we have the unclear procedure of determining or calibrating the interdental clinical attachment loss. On what calibration I can depend to differentiate it as a class 3 and class 2. When I cannot identify which type of recession the patient have, I will doubt the treatment plan I can use successfully. So Cairo came with his wonderful and the functional type. I consider it a very keen and functional classification of root of gum recession, which depends mainly on the interdental clinical attachment loss. And he depends on the fact that when we have a pocket, the first area to be destructed and the critical area to be destructed is the interdental area, the area between two adjacent teeth. Once this area has been destructed, the papillae will be receded. It will affect the aesthetic, it will affect the function, it will cause more root caries and more difficult situation to be corrected. So Cairo came with his wonderful classification with 3 classes of recession type, type 1, type 2, type 3, depending on the amount of tissue coverage at the interdental area. As you see, these 3 categories, they are very different one with different modalities of treatment they need. It was a very nice and functional type of classification. Okay. The results of Cairo's work show that the recession type class is a strong predictor of the prognosis or the final recession reduction. When I have reduction type 1, I can say or put a treatment plan differ from recession type 3 and type 4. I can promise the patient a partially covered or a complete cover. I can promise my patient to solve his sensitivity in his teeth as a problem, or I can preserve the aesthetic part of his smile. These are very different entities. Also, on comparing the Chiros and the Millers, we have another limit of Miller classification. That's when we have a recession of gums. There is a very nice and a critical anatomical factor displayed at the teeth of the patients, which we call it the cemento-enamel junction. Once this anatomical mark had been displayed, the difficulty of treatment will improve itself. So is this line, I can see it. Is there any step? Is there any cavities? Is there any restoration at the area? These will compromise the result of my treatment, whatever the success rate of this procedure. Another wonderful man came to the area, who is the Penny and Pratou. They are friends. They put this classification for the cemento-enamel junction. If I can see it, the case is a class 1. If I cannot see it, the case is a class B. If this line or the cemento-enamel junction is intact of any cavitation or any lesion, there will be a negative sign, or if it has been filled by restorative material, so it will be class B positive, which is more difficult in treatment, needs more work, needs a collaborative work with another specialty to achieve a full coverage. Now, after all that, when we came to our patient, we should keep in mind that the same diagram or the same factors we looked for before, we should consider it the roadmap for our treatment plan. We should think many times before doing our treatment plan by the whole factors causing the recession, not this recession made by a periodontal disease. So I should work it as a periodontal disease. No, there is many factors interplaying that made this pathological lesion developed. Now it's a holistic thinking. We need even the help of an orthodontist to make our treatment successful. Nowadays, we are not thinking of the gingiva as a tissue covering the root merely. I don't care whether it is thin or thick. It's a very important factors to look for. When we have we have to think of the bone morphology, as you see in the picture. It's differ from case to case. Also the tooth position, where it is inclined or declined, where it is out of the bridge. The tooth condition, is it healthy? Does it have any cavitation at the root surface? It all can affect the results. These factors had been put in this table, which enable the periodontist to see at it and put his treatment plan. We should look for not just classifying the recession type, but we should look for all these critical factors to achieve our successful work as good as possible. These are, let me present you some of my cases. This case with a single recession, I treated with coronally advanced flap with a submucosal connective tissue graft. I did a nice job. Why? Because the alignment of teeth were helpful. Okay, I do have a nice thick fibrous tissue, which enables me to pull it, to suture it, to perform a good oral hygiene instructions, and made my patient to do it nicely and comfortably. So I cared about the factors affecting this site and made the recession. By correcting them, I got a complete root coverage. Another case, look at this. I have this recession, multiple recession, okay? One of the, two of the teeth were having non-carious invagination. This is caused by a vigorous tooth brushing when doing a connective tissue graft or with an envelope flap. I got a partial root coverage, which was satisfying for the patient and for me also. Why? Because the main demand of the patient was treating the sensitivity of her teeth. She was not looking for the aesthetic part, and this is very important. We should care about the patient's needs at first. Another case, multiple recession. He came for me for his the ugly looking of his teeth. He said that my teeth looks longer than when they were before. So I have a compromised situation here. I have a very thin gingiva, short attached gingiva or keratinized tissue. I don't have many options for the treatment. So even the best way of treating them, the coronally advanced flap, are compromised in this case. So I choose to do the tunneling technique by Vista technique, which is a single vestibular incision, and I opened the tissues, detached them from the bone. I insert the mucoderm, and this was the last result. Quite satisfying for me, but not completely for him because of the aesthetic. We need more conservative work to solve the problem. The last case I have to show is this case, which is the gum recession caused by periodontal pathological cause. After treatment of the buckets, controlling the situation, I did Vista technique also with complete advancement of the tissues. Look for the last picture, 6 months later. We got a nice thickness of the gingiva from the periodontal point of view, but we still need an orthodontic appliance to correct the alignment of teeth so I can preserve what I got, what the thickness that I got to cover the tissues. At the end, I'm sorry for my long session. For the conclusion, first, before talking to your patient about the prognosis, about the promises you made, you should make and build a good rapport with your patient, gain his confidence in your words, gain his trust in your work, and make it clear for him that 100% root coverage is something compromised by the present factors. Each patient, each tooth has its own factors that affecting the results of the treatment. Also, identifying the cause of the recession can help the dentist or the periodontist to plot a nice and successful treatment plan. Also, the root coverage treatment, you should keep in mind as a dentist and a periodontist that you cannot achieve a nice work unless you collaborate with your colleagues, the conservative specialist dentist, the orthodontist, an implantologist, to achieve that dream or that final result. And thank you for your listening.
Thank you so much, Dr. Sana. That was a very informative session and glad to know about your cases as well. I would like now to open the for any questions for Dr. Sana. Anyone who would like to ask any question to her, please unmute yourself, and it would be helpful if you can also open up your video so that we can see you and you can ask your questions to Dr. Sana. No questions for her? I understand it was self-explanatory. Everything was very well explained. But in case anyone of you has any questions, we'll wait for one more minute and then we'll probably invite another speaker. If there are no questions. So Dr. Sana, very informative
It's
session
okay.
from your
Thank
side.
you very
Thanks
much.
a lot. Thank you
Thank
so much
you.
for enlightening us with all the cases and all the information you had. Thank you very much.
Thank you.
Thanks a lot. I would now like to invite our next speaker, Mr. Rami from KSA. I'm passing him the stage to speak as speaker on research on improving the level of clinician knowledge using EMR. Welcome, Mr. Rami.
Yeah, hi, Assalamu alaikum everyone. Good morning. Can you hear me?
Yes, we can hear you. Mr. Rami, if you can just open up your video as well.
Yes.
Yeah, thanks a lot. Thanks a lot for joining us. Look forward to hearing you.
Thank you. First, at the beginning, I would like to introduce myself. My name is Rami Al Khlaitit from King Fahd Medical City, Kingdom of Saudi Arabia. I am classified as health informatics specialist. I am working in the electronic medical record. We have system, it's electronic health record. We just apply it on 2021. Then as health informatics, we have to keep improving and enhance the system used to achieve all the organization targets. Please allow me to share my presentation.
Sure. You can do that, please.
Okay. The Ministry of Health in Kingdom of Saudi Arabia applied the electronic health record in several government hospitals. King Fahd Medical City is one of the famous medical cities that provides tertiary medical care, and applying one of the best system which aim to improve the quality of the medical services provided. I have some reports. I have some reports to be presented from the system. show how the clinician deal with the system and what is the level of their skill while using the EMR features. Okay. So as you can see, this is the number of employee that has been trained on the system. Almost all the users, because in this system, there's a statement say that if you don't get trained, then you will not have access to the system. So before implementing the system, we have to train all the end users so they will know how to use the system when we implement it. Despite the passage of 4 years of using the system, the facility is unable to reach the required quality and the standard numbers that place it at the beginning.
Üstüme örtmeden çok sıcak hayat. Vallahi çok sıcak.
Sorry.
You may please continue, Mr. Rami. I think it was unmuted.
Okay, so the training management of electronic health record provides training management of electronic health record provides elementary training for any healthcare institution employee to obtain an EHR user. As well as the user would be able to pass through the assessment, and thus the user has an access to practice the required role in the EHR. Although users system, but the reports key indicators which are issued from system shows a gap on what the user learned and they're practicing in the system at the clinic. As you can see from the slide, that the system training management has trained almost all the system users, followed by the new staff in the second year here. Temporary staff also, and intern and volunteers. Anyone will use the system. They should get trained before they use the system. So from this training, and when we keep all the users ready to use the system, actually we expect some results and targets. It's going to be beneficial for the departments and for the organization itself. After we analyze the result and analyze the reports that created by the system, we found that some issues that affect the quality, and we classify it for 3 types of issues: clinical issues, workflow issues, and training issues. EHR usability, known as a major barrier to obtain the provided quality of care. Improving EHR usability is a major challenge. The lack of training in usability or work environment of EHR designers and developers in the vendor company, and EHR analysis making significant configurations in healthcare organizations. Our EHR contain reports tool, diagnostic to track each and every single entry to present the analyzed data as productivity or visualized data. The result of these results can obviously shows the straight and weak areas such as chart correction requests, patient chart deficiencies rate, delinquencies rate, clinical audit monthly reports, and clinical and clinician call for a query are the tools that identifies the level of clinician usage. As you can see here, we classified the issues type as follows. When we say clinical issues, it's just like when we say incomplete documentation and we don't know why. For example, the clinician started a document, then they just leave it without signing or completing all the parts. Sometimes wrong orders, just like when they order for a lab, then it's not complete. And also the privilege misuse, just like when they order, when they place some orders that for a patient who's not in the care, I mean in the care, the facility. Then we have workflow issues. Workflow issues, usually it's fall with the IT team when they don't understand what the end user wants. So when they are describing their workflow and how it should go, then they just miss conditions, or they miss just like when they put a workflow, they forget to add the approve, not approve, yes or no conditions, pass or not pass. So when it's come to be implemented, then this is issue will be reported by the end user. Last is training issue occurred when the trainer is not updating the training environment, neither the training material, or when the developers update the system with big changes without coordinate with training management to prepare the most appropriate method to deliver the changes to the end users smoothly. From the system reports, we prefer actually in this study to typically measure the things that we teach it to the end user. For example, we just focus on one type of the end users, who's the clinician. So they learned in the training sessions how to review the patient history from previous notes, previous labs result, of last X-rays. Providing appropriate training for EHR users can improve their documentation too, which reflect on the quality of the patient participation. diagnostic and patient outcome. Level of accuracy for the medical information is helping the healthcare providers to take appropriate decisions, evaluate risk, review treatment plan, and statistical information. However, some other systems replaced paper documentation with transcribed data after each clinic visit or the discharge from hospital stay. The process called archiving is found to be vulnerable to errors such as mixed patient information or data wrong data. Instead of keep paper documentation and transcribed data, healthcare provider can have basic training allow them to enter the information to the system directly with wide range of saved data which guide the user for every and each field needs to be filled out. This feature allow me to have accurate reports about how the end user use the system and give an impression about how much they struggle to complete their tasks. As you can see, the average time here, this duration can guide you to how you can design your next training and who are your target users. For example, review patient history. It was take just like 1 minute, 15 seconds. Then the complete documentation will take 3 minutes, 11 seconds. Place order, 2 minutes, 41 seconds. Wrap up the visit, take 1 minute. Then review in basket, the placeholder for all the orders need to be approved between the consultant and the resident. Then closing, just like print the next appointment or after visit summary. So to evaluate this training sessions, we design an assessment to evaluate what the clinician do during the visit. So through observation and filling this assessment, we had some good impression about what's happened exactly in the clinic and why some documentation are not completed within the visit, and all that most of the issues that occurred in the report. So depending on the analyzed result to the team and I were able to choose how we will evaluate the clinician skills during the clinic visit. Simply compare when clinician has learned with that clinician practice in the clinic. The evaluation by observing the clinician action on the screen, as you can see, reviewing the reason for visit, update the allergies, review the current and previous medications, review the last lab result, and taking action, and also wrap up to review the medication and patient and family education about the medication and the care plan. We use Google Form to analyze the result. Then, according to the question we put carefully, we got a great result about this study. Then, when we analyze the result, the reinforcement session targeted 70% of the clinician. They found answers for most of their questions and the steps that could not complete while practiced on the production. After they get the regular training, then they practice just like for 2 or 3 months, then they come back to us to get this reinforcement session. It's extra session to allow them how can I complete, for example, discharge summary process, how I can fill the procedure note, how can I review the flow sheet. All of these questions they were able to get answers on when they attend the class. And the clinician who attend only regular training for the mandatory fields, both fill the blanks. That was mandatory. They can apply for a clearance even when they have patient chart deficiencies. Clinicians learned from their colleagues' practices more than what they learned from the class. For example, when we say that it's really important to fill and sign the consent form, but because in some clinics it's not mandatory, so they just leave it until they will be asked by the medical director office to fill it. To get this to get this evaluation right, we had to ask this question at the beginning: do you get extra training sessions? So we will know the difference between the physician, the clinician, they get trained the regular training, and the other clinician who attend for the extra training session. Then we can compare between the two. As a result of this analyzed data collected from the reporting system, health organization must activate and update the policies to use EHR. Systems should set their policies of use and track the end user by regular assessment and disclaimer. System upgrades should be announced and define the changes and verify the training needs. Validate the data provided by the system with subject matter experts before taking a decision depending on the results. Healthcare informatics should secure the user authentication process and active policy to be able to depend on the system records and the reliability of the content. Uh, I'm done with my presentation for the research that I have been made. So, do you have any question? Anyone has any question?
Thank you so much, Mr. Rami, for sharing your research and your research data with all of us. Questions? Any questions anyone have? Please unmute your mic, open up your video, and please feel free to ask the questions. Any questions anyone would have? Can't see any questions coming up your way, Mr. Rami. I think the things which you explained to all of us have been very informative and self-explanatory, and so people are like enlightened with your findings. And thanks a lot, Mr. Rami, for helping us out and sharing your thought process with us and your research and your research analysis with us. Thanks a lot.
Thank you, sister.
We'll now be going off for a coffee break for 15 minutes. We'll resume the session at 10:30. Please join us at 10:30 and we'll resume our next sessions from 10:30 onwards. Thanks a lot, everyone. Hello, everyone. I hope all of us are back from the coffee break and we can resume our sessions. So our next speaker is Mrs. Kuala from the UAE. I'm passing her the stage to deliver the speech on knowledge, attitude, and practice towards antibiotic use with acute respiratory infection among parents of children under 5 years. Over to you, Mrs. Kuala.
Good morning, everybody. This is Khawla Shtayat. I'm from Jordan. I'm a resident in UAE. And today I will present one of my publication, which is taken from my master thesis. I did my master thesis in Jordan University of Science and Technology. Right now, I'm a health educator in UAE. I've been practicing nursing for more than 9 years in different sectors. From school nurse, medical surgical, clinical nurse. I recently being a community health educator and health educators for patients, nurses, and staff. Today, I will talk about, as I said previously, about my publication, which is taken from my master thesis. And I would like to introduce the co-author, my advisor, Professor Nisreen Abu Bakr. She's a community health specialist and professors in Jordan University of Science and Technology. And now I will share my presentation. Okay, the outline of this lectures, I will talk about the background of the problems. I will talk about the objective study, methodology, and the result. And finally, I will go through the conclusion. The background of this problem, as I said previously, my title of this presentation, Knowledge, Attitude, and Practice Toward Acute Respiratory Infection and Antibiotic Use among parents of children under 5 years. Recently, antibiotic resistance has become one of the major global public health problems, although the importance of antibiotic in saving millions of lives. It's increased the mortality rates and treatment cost. Yearly, around 700,000 deaths occur due to resistance infections. The insufficient use of antibiotic is the main reason for developing resistance, especially unregulated usage and self-treatments. Globally, more than 50% of antibiotics are purchasing from pharmacies, private pharmacies, without prescriptions. Acute respiratory infections, ARI, is the most common among children under 5 years. Some of parents are unaware even to differentiate between the viral and bacterial infections, which might lead to antibiotic use. And some of them are unaware regarding appropriate treatment for acute respiratory infection. Parents use large amounts of antibiotics to treat their children's infections, most of which are acute respiratory infections. Previous study also shown that the negative knowledge and attitude and practice toward acute respiratory antibiotic use with acute respiratory infection among parents of children. Also, the studies show there is a link and correlations between the CAP, knowledge, attitude, and practice, with social demographic data of the parents. The objective of a study was, there is 3 main objectives. I can say the first one, examine the relations between the knowledge, attitude, and practice and the parents' social demographic data. Then the second aim to assess the knowledge, attitude, practice itself and toward antibiotic use to treat with acute respiratory infection among Jordanian and Syrian refugees parents who have children under 5 years. And the third objective was to find that if there is any differentiation or any differences between the Jordanian and Syrian refugees parents in terms of their CAP. Methodology. The design, what we choose, it's a descriptive cross-sectional coloration design. Data collection. We start collecting data in December 2021 and we finish in February 2022. We distribute a self-administrative questionnaire for parents who have children under 5 years from both nationality, Jordanian and Syrian. The study instrument was adopted from previous study after we taken the permission from the original authors. The main parts of the questionnaire, we have 4 main parts. Demographic data. We ask in these sections about the parents' education, level of education, occupation, family income. In the second part, the knowledge, it was 7 questions, a true-false question. Attitude level, the third part, we ask a question also, but using Likert scale. And the fourth part was to measure the practice. It was around 5 questions, Likert scale as well. Completing the methodology, and now we're talking about the sample size, we recruited our 204 participants with the response rate 94.4 response rate. After taking also the ethical considerations, we from an ethical approval from ethical community committees, from our university. Publication and sample. The inclusion criteria include the Jordanian and Syrian parents who having children under 5 years and living mainly in Irbid City. Irbid City is the second city in Jordan after Amman. Sitting, it was in local community associations because mainly there is a lots of Syrian refugees who attend and visit these communities. So to find the Syrian refugees, we choose this sitting specifically. Completing the methodology. After we collecting data, we decide to analyze the data using descriptive analysis. Why we use descriptive analysis? To describe the demographic data from means, standard deviation, percentage, and frequencies. The second test, we use Spearman test to examine the correlations between the demographics variables and data what we have and the CAP, and its mean knowledge, attitude of practice of parents. And the third analysis, it's independence sample t-test to compare between a score of Jordanians and Syrian refugees parents. Now moving to results chapter. I know that it's very difficult to summarize the results. This is a publication already. It's published in the Open Journal, Open Access Journal, Open Nursing Journal. So you can find all the full article there. Study populations. After we analyze the data, we find that Jordanian parents form around 60.8% from the total sample. However, and on the other hand, the Syrian parents form around 39.2% from total sample. Moving to knowledge score for both group. Actually, each questions have 1 point, and as I said, the questionnaire for knowledge level, it was 7 questions. Each questions have 1 point. So for both groups, they are the score for both groups from out of 7, 2.85. In Jordanians, 2.94. Among Syrians, 2.73. Moving to attitude score, the total score for attitude was over 70. So for both groups, they get 46.13, and for Jordanian, 46.56. For Syrians, 45.44 out of 70. Regarding practice score, for both group, I can say the total score was 25, and for both groups 17.5. For Jordanian, only 17.92, and Syrian 16.87 out of 25. We finished the first objective of the study. The second object is to find if there is any correlations between the demographic data and attitude, knowledge, practice. We find there is correlations, positive correlations between parents' gender and attitudes. And we find that mother had a significantly higher mean score than father mean. Also, we find the correlations between father education. It was a significantly positive correlation between father education and attitudes. And we find also another result, there is a positive correlation between mother education, attitudes, and practice. Regarding the third objectives, to find if there is any differences between Jordanian and Syrian parents, knowledge, attitude, and practice toward antibiotic use, we find there is no significant differences between Syrian and Jordanian in terms of knowledge, and no significant differences between Syrian and Jordanian in terms of attitude. And there is a significant differences between Syrian and Jordanians in terms of practice and the knowledge. The results show there is the Jordanian had a significantly higher mean score comparing with a Syrian, with p-value less than 0.05. Finally, I will go through conclusion. I try to be concise and summarize the results. If you want to read the article, you can visit the Open Nursing Journal and you can find the full article there. Conclusion, knowledge, attitude, and practice of parents, it's limited among Syrian and Jordanian. And it's a need to improve awareness among these parents, especially who having low social economic status, and Syrian refugees in general, particularly. And there is a need to improve the health insurance policies, because we find there's many parents, they are not tend to visit the doctor clinic, because they don't have enough money to visit the doctor, or they don't have insurance, especially Syrian refugees. Thank you. And if there is any question, I'm ready.
Thank you very much, Ms. Khala, for your research and sharing your observations. Any questions? Please unmute your mic and ask any questions if you have. No questions coming your way. Scholar, thank you so much for your time and for sharing your information. I would now like to invite our next speaker. Our next speaker is Dr. Gelia. I'm passing her the stage to deliver the speech on leadership strategies for improving healthcare professionals' working conditions. Over to you.
Good morning, everybody. It's my pleasure to be with all of you today and to give this presentation about leadership strategies. So I hope you will enjoy it. Just a minute. Okay, so as we all know, the problem of the working conditions in public hospitals have emerged as a significant and pressing topic for healthcare personnel globally. The necessity for a safe, supportive, and pleasant work environment cannot be overstated. It is of paramount importance not only for the well-being and job satisfaction of the employees, but also for the efficiency of hospital management and the quality of care provided to patients. The quality of the work environment directly influences the medical performance, morale, and overall productivity of the staff. Unfortunately, the conditions in which many public and private hospitals operate are far from optimal, as clearly illustrated by the case of Rome, Italy. In Rome, staff members in public healthcare facilities frequently endure high levels of psychological stress and suffer from low morale, often leading to cases of severe burnout. This situation is exacerbated by a multitude of factors. One primary factor is the excessive workloads imposed on the staff. Healthcare workers are often required to work long hours with minimal rest, leading to physical exhaustion and mental fatigue. Inadequate measures for work and psychological support further compound these challenges. There is often a lack of structured programs and resources to help staff cope with the high-stress environment of a hospital. This lack of support can lead to feelings of isolation and helplessness among employees. The quality of interpersonal relationships among staff members also plays a significant role. Poor communication and strained relationships can create a hostile work environment, further diminishing morale and job satisfaction. Ineffective communication between staff and management is another significant problem. When there is a breakdown in communication, it leads to misunderstanding, mismanagement, and a lack of cohesion in hospital operations. All of these factors collectively contribute to creating an unsafe and unsupportive working environment, which not only impacts the well-being of employees, but also negatively affects the hospital's overall performance and the quality of patient care. In light of these pervasive challenges, these studies aim to conduct a thorough investigation into the working conditions in public hospital facilities in Rome. The objective is to identify key areas that require urgent improvement and to propose comprehensive strategies for hospital leadership to address the current situation. By focusing on enhancing the working condition, the study seeks to improve employee well-being, boost morale, and ultimately enhance the quality of healthcare services provided to patients. A mixed method approach was used for this study. In phase 1, 20 participants were selected for individual interviews used to obtain information regarding the status of working conditions in public hospitals. The sample comprised senior managers, operational managers, and staff coordinators from 3 public hospitals. In phase 2, a self-administered questionnaire was used to obtain data from physicians, nurses, and physiotherapists from the same public hospitals, a total of 120 employees. As the goal of the study was to examine healthcare professionals' working conditions in Rome, results are reported for the sample as a whole. Inclusion criteria specified that respondents were to be registered professionals by Italian law, in direct patient contact for the majority of their work time, or in clinical supervisory positions. Assistants and personal care attendants were excluded, as were managers or administrators with direct patient contact, direct patient contact. This study identified several areas of tension. First of all, virtually all respondents were proud to be competent practitioners, yet more than half would not recommend healthcare as a career. There is a clear desire for strong leadership and for a sense of connection between management and clinical staff. This is countered by concerns about the quality of information flow, supervision, and support from management. Respondents expressed a strong preference for autonomy, yet many felt limited in the scope of autonomy granted. Almost all professionals in this study emphasize the necessity of importance of good working relationships with allied care providers. Still, 4 out of 10 rated working relationships with their colleagues as inadequate. Respondents expressed a strong desire for on-the-floor leadership and an increase of involvement in the policy of the organization. As I said before, although the majority is proud to be a healthcare professional, 4 out of 10 would not choose this career again, and more than half have contemplated leaving the profession at some point in time. Even if our study provides evidence that only very few professionals will do so in the near future, many wish to reduce their working hours. This sample study of Rome healthcare professionals documents that the context and the environment in which they practice are a source of tension, dissatisfaction, and weariness. This finding is alarming, given the growing evidence about the relationship between the work environment, the quality of care delivered, and the intention to leave the profession. In the complex and dynamic realm of healthcare, effective leadership stands as the cornerstone of fostering a positive working environment, ensuring workplace safety, and enhancing the quality of care. Healthcare management is pivotal not only in steering organizational culture toward excellence, but also in addressing the multifaceted challenges faced by professionals daily. As the sector continues to evolve, the role of leaders in shaping outcomes, promoting job satisfaction, and safeguarding the well-being of both staff and patients has never been more crucial. Recognizing the significance of leadership within this context underscores the need for strategies that bolster working conditions in healthcare settings. In short, effective leadership is crucial for managing the complexities of modern medical care and ensuring high standards of patient care. Leaders in the healthcare sector play crucial roles in enhancing communication, increasing productivity, and prioritizing patient needs, which are essential for quality care delivery. Sustainable leadership stands out as a comprehensive framework that integrates servant, authentic, and ethical organizations traits. These leaders support and empower employees, fostering an environment conducive to continuous improvement and innovation. By promoting sustainable practices and green management policies, they not only improve organizational performance, but also contribute to long-term success and strong stakeholder relationships. The presence of effective organization is directly linked to improve healthcare outcomes. Leaders who engage in evidence-based practices and optimize resources can significantly enhance patient care and organizational standards. Moreover, a supportive leadership environment increases worker compliance and motivation, thereby improving both team performance and patient health conditions. Despite the benefits, the healthcare sector faces different challenges, particularly in terms of adapting leadership styles to diverse workplace characteristics and mission. The need for professionals with high educational backgrounds in healthcare leadership and strong relational skills is critical to meet these challenges and achieve organizational goals. Leadership is also essential for quality improvement within healthcare settings. Engaged leaders who are actively involved in quality improvement initiatives can accelerate the pace of care improvement. By fostering a culture that supports managers at all levels, healthcare organizations can ensure that improvements are effectively implemented and sustained. In the dynamic field of healthcare, transformational leadership plays a crucial role in driving significant and positive changes, particularly in nursing. This leadership style is essential for creating a supportive and empowering environment, where nurse leaders inspire their teams to achieve exceptional patient care and outcomes. They adopt a management style that not only inspires but also intellectually stimulates their teams, fostering a culture where staff and patient satisfaction are greatly enhanced. Moreover, they foster a cooperative and communicative work environment, crucial for continuous improvement and innovation in healthcare practices. On top of that, transformational leaders take a proactive approach to challenges. Instead of shying away from difficult situations, they tackle them head-on, seeking effective solutions and often involve active input and collaboration from both their internal teams and external patient communities they serve. This approach not only resolves immediate issues, but also contributes to a long-term positive impact on the healthcare system. Key traits of effective transformational healthcare leaders include their ability to delegate responsibility, fostering a sense of autonomy and accountability among their team members. They encourage their teams to exceed expectations through innovation and a continuous drive for excellence. Such leadership not only inspires team members, but also promotes a culture of respect, collaboration, and mutual accountability, which are essential for achieving high standards of patient care. In our demanding and complex field, we know that fostering a collaborative work environment is essential for enhancing patient care and ensuring the well-being of healthcare professionals. In this section, I want to explore the crucial aspects of promoting teamwork, facilitating effective communication, and resolving conflicts to create an harmonious setting. Teamwork is the backbone of effective healthcare delivery. It not only improves patient outcomes, but also enhances the job satisfaction and efficiency of workers. In environments where stakes are high, the integration of efforts from nurses, doctors, and support staff is critical. Effective teams in healthcare are characterized by clear communication, shared goals, and mutual respect, which facilitate improved health outcomes for patients and a more satisfying work environment for the staff. Communication is a pivotal element of a collaborative workplace. It involves more than just exchanging information. It requires active listening, understanding, and responsiveness. Healthcare leaders must ensure that team members have the skills to communicate effectively, which includes the ability to discuss and resolve misunderstandings promptly and efficiently. This is particularly important in high-stress situations where clear and concise communication can prevent medical errors and enhance patient safety. Providing training in communication skills and creating spaces that encourage open dialogue can significantly improve the team dynamics and overall effectiveness of service. Conflicts are an inevitable part of any workplace, especially in high-pressure environments. Effective conflict resolution involves understanding the underlying issues and addressing them constructively. Healthcare leaders should be equipped with the conflict management skills to guide their teams toward resolution and maintain a positive work atmosphere. Strategies such as promoting empathy, encouraging open communication, and seeking compromise help in resolving disputes and reducing workplace tensions. Additionally, adapting structured conflict resolution mechanisms, such as the Thomas Kilmann conflict mode instrument, can aid leaders in selecting the appropriate strategy for different conflict situations. By emphasizing these key areas, so teamwork, communication, and conflict resolution, healthcare organizations can foster a collaborative work atmosphere that not only supports the professional growth of healthcare staff, but also enhances the quality of care provided to patients. So, how can we support healthcare professionals across their daily work and beyond within cure and care to help make this sector more attractive and thus most sustainable? I believe we can just have a point of view on the future. We need to be proactively designing, validating, and building it. For this reason, I would like to say something about how we can provide resources and support, how we can encourage professional development and ensure psychological safety. Healthcare systems are recognizing the need for solutions that promote professional development without disrupting workflows. Continuing medical education is essential for clinicians to stay compliant and updated on health equity and best publication practices. Additionally, access to efficient and comprehensive professional development resources is crucial in the continuously evolving healthcare sector. These resources not only help clinicians maintain licensure and certifications, but also support broader goals such as understanding the diversity, equity, and inclusion on how unintentional bias impacts care. Professional advancement is crucial for employees' growth. By conducting a need assessment, healthcare organizations can identify the specific needs of their professionals, helping to tailor specific programs that enhance their competencies. Ongoing coaching and mentoring are also vital, providing guidance and feedback that foster skill development and expertise. Moreover, organizations are encouraged to involve their employees in quality improvement initiatives. This involvement not only enhances learning, but also improves the professional's ability to deliver exceptional care. Recognizing the contributions and achievements of healthcare professionals can further motivate them to engage in continuous learning and development, thereby fostering a culture of growth and improvement within the healthcare settings. Psychological safety within teams is really important in order to foster an environment conducive to open communication and innovation. Facilitators of psychological safety comprehend leader inclusiveness, open culture, and support within teams, which all contribute to a non-judgmental and supportive atmosphere where individuals feel comfortable and confident. Barriers to psychological safety, such as hierarchical structures and authoritarian leadership styles, can significantly impede the free exchange of ideas and concerns, potentially leading to increased medical errors and decreased team morale. Interventions to enhance psychological safety are multi-level and include providing time for personal discussions to build trust, encouraging one-on-one interactions to foster individual relationships, and promoting the value of all team members, especially those of low psychological safety, like junior team members. By prioritizing psychological safety, healthcare organizations can not only improve the quality of care, but also support the mental and emotional well-being of their staff, leading to a more engaged, motivated, and effective workforce. Burnout among healthcare professionals is a psychological response to chronic workplace stress, characterized by exhaustion, increased mental distance from one's job, and reduced professional efficacy. This condition not only leads to decreased job satisfaction, but also impacts patient care adversely, resulting in medical errors and reduced quality of care. Addressing burnout effectively involves managing workload, providing professional development opportunities, and fostering a supportive work environment. As a way to mitigate burnout, organizations are encouraged to implement strategies such as limiting duty hours and ensuring adequate staffing and flexible working schedules. Additionally, individual-focused intervention like mindfulness, stress management, and small group discussions have proven effective in alleviating burnout symptoms. Healthcare companies need to provide access to mental health resources, confidential support, and encourage self-care practices among their staff. Moreover, establishing burnout prevention and wellness committees can also help review and improve work environment, team dynamics, and organizational culture. In conclusion, we have explored the multifaceted role of leadership in enhancing working conditions within the healthcare sector, emphasizing the significance in shaping organizational culture, employee well-being, and patient care outcomes. The discussion highlighted the critical aspects of healthcare leadership, including the importance of identifying key leadership competencies, fostering a collaborative work environment, and addressing challenges like psychological safety, burnout, and job satisfaction. These elements collectively underscore the central role of effective leadership strategies play in not only navigating the complexities of healthcare management, but also in ensuring high standards of patient care and fostering a supportive environment for healthcare professionals. In light of these insights, it becomes of supreme importance for organizations to provide and prioritize leadership development and implement strategies that resonate with the core values of empathy, collaboration, and continuous improvement. By doing so, they can create a resilient workforce capable of adapting to evolving healthcare demands while maintaining a focus on quality patient care and employee satisfaction. So, the call to action for healthcare leaders is clear. Embrace transformational leadership practices that inspire change, empower professionals, and cultivate an environment where both staff and patients can thrive. As the healthcare landscape continues to shift, the role of effective leadership in driving positive outcomes and innovation in patient care will undoubtedly remain indispensable. Thank you very much.
Thank you so much, Doctor. That was very interesting. I would like now to invite the participants, if they have any questions, please feel free to ask any questions to her. Unmute your mic and you can ask the questions. You're waiting for the questions. Thank you so much, Doctor.
Thank you.
A lot. Thank you.
Hello.
Anyone?
Good morning.
Yeah. So I would now like to invite Ms. Laila as our next speaker. I would like her to please take the stage and to deliver the presentation on improving hypertensive patient adherence to OPD appointment, a solution for reducing complications and emergency visit. Over to Ms. Laila.
Hello. Good morning, everyone. It's my pleasure to be with you today. Today, inshallah, I will talk about our project. The project is appear in our mind when we notice an EMR, the system, there is a lot of patients have appointments in the clinic, but they not show in the appointment. So this project is to improve hypertensive patient adherence to the appointments. The issue, some hypertensive patients discontinue their treatment plan, leading to complications and increase the emergency visits. We do a quick search and we found high blood pressure.
Miss Laila, I'm sorry to interrupt you, but we are not able to see your slides. If you can share the screen.
Wait.
Yes.
You can see it now?
Yes, we can see it now.
I don't know. You can't see now?
We can see it now. Yeah.
Okay. Do you think I should start it from beginning? And now you can't see my screen. Or still?
Still, we are not able to see you.
Still not see my screen? I will
The slides are not visible, Ms. Laila.
get me. What about now?
Yes, they are visible now.
Mm.
I think you can just keep it like that only without that
Okay.
slideshow. Because when you are doing that slideshow, we are not able to see the screens. Maybe you can just,
Okay. I will start it again here. In our clinic, we not see the hypertensive patients, so we are improving our project to be help this patient. So the issue is some hypertensive patients discontinue their treatment plan, leading to complication and increase the emergency visit. So we do a quick search and we found the high blood pressure is leading to death. In 2023, Ministry of Health reports a revalid concerning number of deaths attributed to high blood pressure, 702 out of 85 total of death in the city, and this is a huge number. So the other risk is missed point and equal to increase the risk for the patient. So a study shows a direct link between the hypertensive patient missing appointment and the emergency room visit. The last one is financial burden research from King Fahd Medical City highlight the significant financial strain caused by the patient not attend the appointment. So we searched about the solution and we generated 3 points to solve this issue. We create a report from our system to pull out the patient who have not scheduled appointment within the past 6 months. You know, for the patient with hypertensive, is taking 1 year appointment in each year. So if he has appointment and after 6 months he doesn't show, he take 1 year and a half. So in 1 year and a half, it's leading to a lot of issues, and maybe he need to change the medication dose and change the medication at all. The second solution is contact the patient directly by phone, because when we check with the patient, we found most of them is they cannot write reading the text message. So this is why they not attend their appointment. The last solution is work with patient to reschedule appointment and ensure continuity of health care. We take a random sample, and this is the first patient. As you see in the file, there is a no-show for this patient. So we contact him and we see ask him why he is not attend this appointment, and he said he cannot read the SMS message, and there is no one to can read for him. So we scheduling for him this appointment, and as you see, he coming and complete his treatment. The second one, it's there's 2 appointments and she not show. When we contact her, she said she has a conflict with operation, so she doesn't know how she can reschedule the appointment. So we teach her how can she reschedule her appointment, and we submit for her a new appointment, and she attend, alhamdulillah. The last one is it's a patient, he cannot he doesn't like to continue her treatment with this physician, so we send her with another physician to complete her care with the clinic. So the target population is the hypertensive patient, is diagnosed with high blood pressure, and the age group is for 50 years and above. And the appointment gap for the patient who have not scheduled appointment within the past 6 months. And we put the location for the second Riyadh Health Cluster. A project expansion plan. Stage 1 will be each stage will be for 1 year, and the stage 1 will be hypertensive patient, age above of 50 years, who have discontinued their appointment for more than 6 months. The stage 2 is hypertensive patient age more than 18 years who have discontinued their appointment for 6 months and more. The stage 3, diabetic patient age more than 50 years who have discontinued their appointments for more than 6 months. The last stage is the stage 4, will be diabetic patient aged more than 18 who have discontinued their appointment for more than 6 months. The project impact will be improve appointment adherence for the hypertensive patient, lead to fewer complications and emergency visits, and ultimately a healthier future for everyone. And this is the last slide. Thank you so much for all of you.
Thank you, Ms. Laila.
Thank you.
Any questions from the participants? Do we have any questions for Ms. Laila? Can't see any questions coming your way, Ms. Laila. Thank you so much for joining us today. I would now like to invite our next speaker.
Thank you so much.
Ms. Amaya. I'm passing her the stage to deliver the speech on advanced practice nursing, new challenges and advances in nursing. Ms. Amaya.
First of all, I would like to thank the organizers for the opportunity to make this presentation at this Congress. I am Amelia Melendez. I'm nurse and I have been working in an intensive unit care for 8 years. I will be my introduction for my presentation, Advanced Practice Nursing, New Challenges and Advances in Nursing. The advanced practice nurse is a registered nurse who has acquired expert knowledge, has acquired complex decision-making skills, and has the clinical competencies to develop their practice. All of these competencies are accredited based on the country where the services are provided and the regulations. What determines these competences are expert knowledge, clinical skills to take responsibility for patients, and the autonomy to make complex decisions. In addition, the use of advanced assessment system, diagnostic judgment, and the competencies that these professionals have with respect to research, teaching, and care management will be the key. The origin of advanced practice nurses is found in the United States in the middle of the 20th century, when the nurse practitioner and the clinical nurse specialist appear and are recognized worldwide. Both emerged at a time of need. Also, the figure of the clinical nurse specialist is one that is framed within the nursing care itself. In 2008, the International Council of Nurses defined the advanced practice nursing as a nurse with expert knowledge, the ability to make complex decisions, and the clinical competencies necessary to carry out and expand practice, recommending a master's level education. But it's not until 2020 when the International Council of Nurses launching advanced practice nursing guidelines that defines the advanced practice nurses as a nursing professional who provides safe and competent care to patients. They base their actions on nursing education. They perform roles that require academic training beyond that of a generalist nurse, and they present the ability to explain and to apply the theoretic, empirical, ethical, legal, and professional development of care delivery. But it's not until 2020 when the International Council of Nurses defined as well that nurses have to have defined the advanced practice nursing standards and competencies, and they are influenced by the global social, political, technical, and economic environment. All these guidelines highlight that the advanced practice nursing has a role mainly based on the principles of the profession to provide an adequate capacity to maximize and promote comprehensive health care services. The objectives of this presentation is to determine the current situation of the advanced practice nurses around the world and knowing the functions of advanced practice nurses. I've done a bibliographic search, was performed in different databases and online repositories. I have established language limits for English and Spanish and chronological limits for last 10 years. Then I have done a critical reading of the articles found, was carried out, and duplicities were eliminated. And I have done exclusion criteria for nurse specialist practice and medicine. Currently, there is evidence of the effectiveness and benefits, mainly economic, of this type of nurses. It establishes that the quality of their care, especially in areas of primary care, cardiology, critical care, and anesthesia, can be favorable to these units. In different countries, it has been shown that the level of training of advanced practice nurses is related to the performance of advanced practice activities. Most of the countries have implemented these programs, have a specific training for access to this role, and the inclusion of clinical simulation is necessary. Unlike Spain, countries such as France, Botswana, Australia, Bahrain, Canada, Hong Kong, Japan, Ireland, Iceland, Jordan, Korea, Macau, Philippines, New Zealand, Holland, Thailand, Sweden, Taiwan, Singapore, South Africa, Great Britain, and the USA have developed advanced practice nursing roles. And it should be noted that in other countries, this figure is already emerging. In the first advanced practice nurse program in Great Britain, in 1992, about 15 to 20 nurses were graduated. These students paved the way to the thousands of advanced practice nurses that exist today in that country, being a reference in skill lessons, methodology research, and in other areas. They need a specific training, clinical practical experience, and they have to pass a nationality certified exam to have their license. But in Spain, also they need teaching and research. In Spain, the lack of development of the advanced practice nurse in Spain has a favorable side. It is possible to learn from the experience of another models and another countries to develop the model that can have a greater find realized. And analyze could be useful and to develop an evidence-based policy. On the other hand, if the necessary support were available, it would be possible to carry out this project more quickly. Entities such as the International Council of Nurses, the World Health Organization, and other organizations have resources and professional expertise that could be useful for this purpose. However, in Spain, there are also certain limitations to the development of these training programs, as the limited number of highly qualified teachers and the limited number of clinical practice positions. But small steps can also achieve great results in the medium time. There is important to allow that not all nurses working in a country have and should be an advanced practice nurses, because this figure should be created to respond to specific problems, and it had to be accessible, which would make it possible to carry out this work both in person and remotely, and on part-time or a full-time basis. In Spain, we have the advanced practice nurses in midwifery, mental health nursing, geriatric nursing, occupational nursing, and pediatric nursing. And in Spain, have another problem. In Spain, there are different communities have included figures with innovative profiles that develop a practice competence of greater complexity and autonomy than that provided by the title of a general care nurse, mainly in chronic disease. Some of these cases are the nurses in urgent care for minor illness in primary care in Catalonia, home and hospital care case management in Andalusia, advanced clinical nurse practitioner in the Basque Country, and professional accreditation in Andalusia for oncological advanced practice nursing, and the advanced practice nursing in care of people with complex chronic wounds and in care of people with with ostomies. Among these, the nurse case manager is the most common figure, and it is present in addition to Andalusia in more autonomous communities such as the Valencian community, Murcia, Aragon, Madrid, and Navarra, among others. However, none of these roles requires a specific postgraduate training, and none of them coincide exactly with the traditional roles of nurse practitioner and clinical nurse specialist. In Spain, we have specific programs to encourage our professionals to improve their research and evidence, and we are working with such the nursing research challenge. That's a program to introduce the advanced practice nurse into research for improve these profiles. To conclusion, the development of the advanced practice nurse in Spain should be preceded by an adequate analysis of the situation, together with planning for the future, as well as an adequate legislative framework. The experience in other countries should be taken advantage of, and help should be sought from international experts, contributing positively to the development of the evidence-based practice. And in the practice, they integrate 4 roles: clinical expert, consultant, teacher, and researcher. Nurses who develop this profile are professional nurses who exercise clinical leadership in their field of work, with autonomy to make the complex decision based on the application of the evidence and research results to their professional practice. Thank you so much, and I'm waiting if any have any question.
Thank you so much, Ms. Maya. Any questions for Ms. Maya? Gone very silent today. Any questions for her, please? Thank you so much, Ms. Maya. I would now like to invite our next speakers, Ms. Maria Jessica and Ms. Mona Farhan. I'm passing them the stage to deliver the speech on revolutionizing inpatient focusing on medicine department, medical services, by creating a multi-collaborative framework in achieving strategic objectives in King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. Over to you, Mr. Maria.
Okay. Good morning, everybody.
Good morning.
Good morning, everyone from Saudi Arabia. My name is Mona Al-Anisi, and I have my colleague. Her name is
Ms. Maria, you're not audible properly. I mean, your sound is coming from far behind, it seems. You can just
Can you hear us right now?
Yeah, it's better now.
Okay.
Okay, so good morning again, everyone. My name is Mona Al-Anisi, and I have my colleague. Her name is Maria. We are a clinical care coordinator.
We're losing you, Ms. Mona. We're
Sorry?
losing you. We are losing you, your voice. I mean, I think both of you are presenting together. So if you can both be near the mic, it'll be better. We are not able to hear you clearly otherwise.
Oh, just a minute. Huh?
Yeah.
Can you hear us right now?
Yes, it's better.
Okay, so now we'll start to share. Okay. Just a minute. Okay. I'll share the slide. Okay. Slide, so from the beginning. Can you see the slides? Anybody can see the slides?
Yes, we can see the
Yes, go
slides,
ahead.
please. We can.
Okay, good. All right.
Okay, so before we start our presentation, we would like to take this opportunity to thank the committee behind the success of the online website and giving us the platform to present our presentation.
Miss Maria, is Miss Mona with you sitting there? Because when she starts speaking, we are not able to hear her, though we are able to hear you properly.
Can you hear us right now?
Yes, we can hear you, but I don't know what's happening because when she starts speaking, we don't hear her.
Okay, I'll just try one more again. Can you hear me right now?
Yes,
Is it clear now?
it is clear now.
Okay, I'll start from the beginning. So before we start our presentation, we would like to take this opportunity to thank the committee behind the success of the online and on-site of the conference and giving us the platform to present our presentation involving the collaboration between the Department of the Medicine and us as a clinical care coordinator in King Faisal Specialist Hospital and Research Center, Riyadh branch. So our abstract title is okay. So our abstract title is Revolutionizing Inpatient Focusing on Medicine, Medical Service Department by creating multi-collaborative framework in achieving strategic objectives in King Faisal Specialist Hospital and Research Center area. The abstract itself focusing in the following, which is improve operational efficiency to give a priority and effort aligned with the hospital strategic objectives. And the most important thing as a clinical care coordinator, focusing on the KPI, the key performance indicators, such as decreasing average length of stay. There are 6 objectives. I will give importance to it for patient care measure and the specific clinical intervention and connection of the length of stay, streaming the frequent disease under medicine, internal medicine being admitted in emergency, to give a pathway on the flow of patients being admitted and having the discharge plan initiated, and we'll explain further in the following slides. King Faisal Specialist Hospital and Research Center Medicine Department is instrumental in providing high-quality medical care and advancing the field through research and education. It's a comprehensive services and patient-centered approach make it a cornerstone of the hospital's operation. We have 7 medical services under the umbrella of the medicine. General medicine, gastro, pulmonology, nephrology, rheumatology, endocrine, and infectious disease. Okay, so the pathway flow of patients, we need to understand how patient being assessed, evaluated, and intervention being made, and the strategy plan to put it into place. So we have 9 steps. We'll talk about it one by one. Starting with the ATS, admission tracking shell. The tracking shell will show us the patient being admitted in the emergency with the different services. Here, the bed board. Bed board, it means, or when the patient are boarded and admitted in the patient area, also monitoring the vacant beds for admission and potential or possible discharges. Bed capacity management, showing us the possible and confirmed discharges across the hospital-wide. Here, the patient flow department of the emergency and inpatient unit. This flow will indicate the occupancy rate for both emergency and inpatient area, also showing as the pending procedures, for example, radiology requests or confirmed discharges to be expedited. Power chart ICES, in King Faisal Specialist Hospital, we're using the Citrix program, high performance access to all healthcare provider. In Power Chart, we have the medical team will place an order to create a specific diagnostic and medical plan for the patients. The estimated length of stay, this is the most important for us because it will give us up to when the patient will be admitted in the hospital. And also as a clinical care coordinator, we have to track the patient before reaching the estimated length of stay by following with the medical team regarding the discharge plan. Here, admission assessment to be done by the primary nurses once patient admitted in the inpatient area. Discharge checklist also to be done by the primary or chart nurses once patients are confirmed discharges. Okay, here the resources for the discharge process. We have a multiple resources, starting with the home discharge, which is regular discharge, referral to the home health care. It's a care being followed up by the medical team from the hospital when patient at home. Long-term facility when a patient requires a long hospital stay and medical nursing care. Short-term facility when a patient will stay for a temporary time or temporary stay in the hospital, such as a short patient, he needs a short duration of antibiotics or like monitoring of the certain tests. MOH also we have a resource, Ministry of Health. It's a referral back to their own local hospital. For example, if the patient is going back to their own city, in Asir or Dammam or Jeddah, or also patients sometimes will be referred by the Ministry of Health according to the patient medical status to any kind of the facility. And here, last one, you could see from the picture that patient doesn't want to leave the hospital. So we can address this issue with the alternative level of care with the multidisciplinary team, including the medical team, care coordinator, and patient relation. And the following slides will be presented by my co-speaker.
Okay, now that we have discussed about the patient flow and what spin medicine is all about, the umbrella that is, and what medicine can contribute to the King Faisal Specialist Hospital in Riyadh. Now I'm going to talking about the projects and what we did in 2024. First and foremost, we have an initial meeting with internal medicine, the focus area, because we know for a fact there's a lot of issues and concerns to be brought upon and to address with beginning of the year. We also highlighted with these issues and we designated a 6-month action plan for this one. And also we're going to be showing to you the statistics from 3 years to 2022, 2023, and the first and second quarter of 2024. And of course, I'm proud to say that we also initiated a power plans that we're going to be issuing. It's going to be across the board between the branches in Medina, Jeddah, and specifically in Riyadh as a pilot area. And also we have to also have the projects initiated by our fellow inpatient units. Let's go further with the following slides. As you can see, we have the minutes of the meeting. It's being collaboratively done with the section head of medicine as the clinical coordinator, the patient relation, the different nursing teams. We address issues that's been presented for the past few years, and we're trying to address these issues with the specific plan, with the specific people that involved with these issues as well. Okay, bringing forth, also you could see how we address these issues on this minutes of the meeting. presented. As you can see, the action plan place, there's a lot of numerous action plans within place, but to give you a few tips, okay, we increased the manpower of the pharmacy because we're facing a lot of issues regarding about issuing discharge medication. So increasing manpower like 2 to 3 people during the peak days. We have our own ecotech because echo is being done as part and parcel of the initial intervention of patients being admitted in inpatient area. We also review, as my colleague mentioned, we review radiology requests, procedures every single day to avoid delay of diagnostic exam and medical plans for these patients. In addition to that, the proper escalation of issues should be practiced among us and a proper communication for the rest of multidisciplinary team, which is initiated by weekly MDR meeting with our fellow medical team in the inpatient unit. Apart from that, we are also practicing proper discharge plan for our patients with concrete collaboration for our own team and other team members in the inpatient unit. As I mentioned earlier, we also initiated a power plan care set that is demonstrated with the 6 common diseases under internal medicine. I'm proud to say that is already under HITA for approval and review. Once it's going to be approved, it's going to be going live, not only in Riyadh, it's going to be live in Jeddah, in Medina, across the branches of King Faisal Specialist Hospital. And we are proud to say that it's a concrete collaboration between the clinical care coordinator and with the Department of Medicine in order to have a concrete plan for decreasing the length of stay of our patients. Okay, to move further, I'm also demonstrating to you our discharges in year 2022. You can see that our discharges below 9 days, we are having 88% to 90%, and the remaining percent, 22%, is those patients having 9 days and above, which is having complex cases or needs further medical evaluation. Furthermore, in 2023, the same atmosphere, we're also trying to meet the target margin. Our length of stay for 9 days and below, we're also meeting 88 to 92%, and the rest also, as I mentioned earlier, with the complex cases that needs referral to other services. Lastly, on this year, we're trying to beat that. First and second quarter, there's an increased margin of patients being discharged below 9 days. You could be hearing me, why am I emphasizing 9 days and below? Because this is part and parcel of our KPI that we need to discharge patient below 8 days in order to have that target KPI project across the hospital-wide. And also, I want to mention, there are also initial projects, not only us, but also our fellow inpatient units and the medical units. We're also initiating the reducing average length of stay for stroke open window. It also means that if a patient's admitted for open window, they will be diagnostic tests immediately, and they will make their medical plan immediately, and the patient will be discharged 3 to 5 days without even sacrificing reaching the 8 days grace period. Also, one of the units initiated a discharge checklist, which showcase the early assessment and evaluation of what needs to be done for a patient being discharged in an inpatient unit. And lastly, as the clinical coordinator, it's our part and parcel to educate, to give additional education to our fellow medical team, that we have resources internally and external resources like the contracted hospital for those kinds of patients that need King Faisal facilities. That is ongoing education for our fellow medical team as well as the rest of the people who's going to be assigned in the medical unit. And this is our resources for our presentation for this afternoon. For any questions, this is our contact email. Both are work email, me and my colleague.
Thank you, Ms. Maria, and thank you, Ms. Mona, for your speech. I would request anyone from the participants and the audience today, if they have any questions for them, Please feel free to ask. Thank you for a very elaborative and a very kind of informative information about your project, Ms. Maria. That was really very helpful for the participants, and I think it's so and kind of engaging that the people don't have any questions for you as well.
Yeah, I know. Before I part, I just want to give a conclusion that as a clinical care coordinator, because we're nurses, we give a concrete impact for patients' outcome because of concrete collaboration and connection with different teams, especially medicine, because medicine is medicine, like they're medical doctors, but we nurses, we need to be imparted with a lot of education processes and those things that will impact patient care, especially in King Faisal Specialist Hospital. We take these things seriously. Yeah.
Definitely, Ms. Maria. I mean, I always have believed that nursing teams and the nurses, they are the backbones of any medical practices.
Yeah.
I mean, without them, nobody would be able to do anything, actually.
Correct. Yeah.
So anything from our side which helps them, anything, that's really welcome. So we got a thank you.
Yeah. I just hope the rest of the team was able to get something out of our presentation, because the one way what they think to do an abstract is to educate, to give the kind of practice we usually do, especially in a tertiary hospital, and one of the key points of giving an abstract is to education. And that is our key points for this presentation.
Yeah. Thank you so much. Thanks a lot, Ms. Maria.
Thank you very much, everybody.
Thank you. I would now invite Professor Asma to deliver her speech on health systems for elderly in the Arabian and Gulf region. Professor Asma. Dr. Asma, are you there?
Yes, hi, good morning. Yes, I'm there.
Good morning, good morning. Your presentation has been, I mean, a little bit preponed because of whatever. Thanks a lot for joining us. We wait to hear from you, Dr. Asma.
So are you going to share the presentation from your side or from my side? I thought you are already prepared. Give me a second. Actually, I thought you were going to prepare it from your side. So sorry for this.
No worries, Dr. Asma.
Okay, here we there. Sorry for the delay. Is
No
my
worries,
clear
Dr.
voice? Okay. Good morning from Vienna, and I don't notice the time. Good afternoon in Dubai for everyone here. My name is Dr. Asma Limni. I'm a professor of healthcare management teaching King Saud University. My pleasure to being with you today. I will talk about the spectrum of geriatric healthcare in Gulf region. The aim of this review study to highlight the main current health status and healthcare issues for elderly population in Gulf regions, and to explore the main reported healthcare intervention and educational initiatives that aim to enhance elderly healthcare, and to explore any regional variations and the implication for policy and practices. Actually, to start with, what are geriatric medicine? It is a specialized field that focuses on providing healthcare to elderly population, and it is involved identification, management, and prevention of a disease and disability in elderly population. The demographic transformation in the region present specific difficulties and potential also for the healthcare system, and required concentrated analysis for geriatric medicine, and that's why we conduct this study. There is an increasing in the percentage of elderly population. We can see that most likely in Qatar has a high life expectancy reaching to 81, following by United Arab Emirates and Oman and then Saudi Arabia.
Dr. Asma, sorry. Dr.
Yes.
Asma, sorry to interrupt you. If you can rotate your phone, your slides are like not coming properly. If you can just rotate your phone from the portrait to the landscape mode. Yeah.
Is it okay now?
No, I think you have to rotate the screen of your phone.
One minute, please.
Yeah, sure.
Is it
fine now.
okay?
It is okay now.
Thank you very
Thank
much.
you.
Okay.
Thank you.
So okay, going back to the life expectancy chart, as the percentage as you see here, and the expectation as of 2023, around 7% of population of Gulf countries is age 60 and above. According to the report produced from Deloitte in Life Science and Healthcare Prediction, it was produced in 2018, they estimated that quarter of GCC population would be over 65 by 2050. So this are currently increasing population growth, also increasing life expectancy and higher incidence of non-communicable disease. Also, from another perspective, social norms of the Arab world give special respect and status to the elderly. There is a social pressure on the families to look after their elderly within the family. And there is also social stigma associated with using home health care or care homes, nursing homes, and that have impact on the healthcare delivery. Also, there is some report indicating there is a significant progress in healthcare infrastructure, especially for geriatric medicine. However, in comparison to the Western nation, is still lacking in development. From other side, there is a lot of joint health work between GCC governments in different aspects of healthcare. For example, there is food safety committees, there is for pharmaceutical control committees. There is a lot of joint work for registration, the physicians at the GCC status. However, there is low concern given to build some solid joint work for in geriatric medicine field. The research methodology, we utilize a systematic literature review to gather secondary data from scientific sources for analysis. Our researchers database from Google Scholar, from Science Direct, PubMed. The inclusion and criteria focused on studies that concerned about 60 and above age group in the Gulf region. And we included cross-sectional observational retrospective studies. And these the following chart, we follow BRESMA flow chart, BRESMA method, a principle to guarantee transparency and thoroughness in the review process. After meeting all the inclusion criteria, a total of 25 papers were assessed for final systematic analysis. Our main research findings, it is related to our objectives. For the first objective, to assess current status of health issues and healthcare issues for elderly people in GCC countries. The main findings, there are increasing incidence of chronic disease such as diabetes, hypertension, cardiovascular illnesses, and dementia in the elderly, which call for specific medical attention. Also frailty, falls, and urinary incontinency and malnutrition, also a common health problems relating to those chronic incidents has been reported in multiple studies. The second objective, to explore healthcare interventions, the most healthcare interventions and education initiatives designed for enhancing elderly health care. There is analysis show that there is limited development in home healthcare services. Even though there's some geriatric department in major hospital has been established, however, we have shortage of geriatricians and nurses specialized in that field, which is considered should consider the policymakers. And for the research finding 3, or which to explore regional variations, the study show us there is a considerable gap in accessibility of healthcare services for older population between GCC countries. We will go for each main findings. For example, for prevalence for the current health issue, prevalence of chronic conditions, diabetes has been estimated from 37 to 63 among elderly population in GCC countries, while for hypertension from 22% to 49%. Also, there is some kind of what we call the health-related quality issues associated with these chronic disease. For example, virility and concurrence falls because of decreasing vision and reported mobility difficulties for elderly population. Also, there is some report show increasing significant occurrence of mental health issues such as depression and dementia, and this psychiatric disorder has been increasing significantly, especially in after COVID period. The other healthcare issues has been reported. It is the medication adherence and potentially inappropriate prescribing. The medication compliance and the utilization of potentially inappropriate medications, it is really an important concerns that should be highlighted in the Gulf area. It has been documented the medication adherence rate, the lack of medication adherence to become 64% among senior patients. This percentage is considered high, and it is impacted by various factors, including patient behaviors, lack of their health knowledge or health literacy, including also the number of pills they have to take every day. The most medication that was reported as inappropriate medications, it is more with proton pump inhibitors and non-steroidal anti-inflammatory drugs. Also, there is a significant increase of utilization for emergency department from senior patient. 90% of those who visiting emergency departments, they are from elderly population. There is also a high admission through those emergency department. Rate reached to 28%. Mortality rate 1%, which highlight urgent requirement for enhancing acute care and emergency service specifically designed for elderly population. To explore the main healthcare interventions and educational initiatives to enhance health elderly population, there is some initiative to invest in development home healthcare service. In United Arab Emirates, they investing above 28 million in 2019. And also in Saudi Arabia, they do the same. And when we try to identify healthcare home health services, we mean those services or that specified teams who take care of wound and pressure sores or surgical wound, the visiting patient in their homes, and they try to educate patient and the caregivers. Also, the intervention they provide relating to nutritional assessment and therapy, they provide injections and monitoring the chronic and unstable health conditions. The key drivers for home healthcare, for development home healthcare in GCC, it is really very important as the aging, increasing the number of elderly population. Also because they investing highly in technology, especially the remote monitoring for unstable health conditions in home, and because of also some cultural aspect, most of the elderly patients and their families, they provide to having a convenience, a comfortable home care. The challenges for that, it was shortage of licensed health care professionals. For example, in Saudi Arabia, we have only 20 licensed geriatricians, and also shortage of professional caregivers. And those who providing the caregivers, they are who provide daily assistance to ensure that activities of daily living is going on for those patients. The most educational initiatives to enhance elderly healthcare has been emphasized in the literature. They first of all highlighted there are some deficiencies in understanding of geriatric care among physicians, especially those the family physicians and those in emergency care. So it is important to including in the medical curriculum, in the medical schools, courses on relevant geriatric disease, and also to educate them about or to addressing polypharmacy. Accepting or integration or introducing pharmacist-led medication reviews is very crucial as a strategy for reducing inappropriate medication use and enhancing practice, geriatric care practice. Regarding also the objective to explore interventions and education initiative to enhance elderly health care, there is a lot of recommendation to enhance medication and medication management and reducing policy pharmacy, as we mentioned before, by establishing what we call this peer review or pharmacist-led medication reviews. Providing some training for nurses and for physicians, The second strategy also enhancing chronic disease management and promoting preventive healthcare wellness program. The in-depth analysis shows geographical disparities in the condition of geriatric medicine throughout the Gulf countries. Qatar, United Arab Emirates, Saudi Arabia, and Oman have made notable advancement in tackling elderly healthcare concern. Although Iraq, Kuwait, Bahrain, they still encounter substantial obstacles in this regard. For example, in Bahrain, the most intervention they provide to monitoring healthcare for elderly or enhancing healthcare, they establishing mobile units for elderly consisting of a specialized team, like a nurse, a home visit technician, a health driver, who in this unit start from the primary healthcare centers. And these teams make home visits to the elderly to provide them with necessary healthcare. We move to the end of the spectrum. In Qatar, for example, they have more advanced network of home healthcare provided for the elderly, connected also with the primary care services. And they're providing, these departments provide services to offer to all the population over 60 years of age. Also, another example in Emirate, in Dubai, for example, they have very advanced center of excellence for healthcare services for elderly. For example, the Fight Elderly Care Complex in Dubai, which is providing advanced nursing home, Alzheimer Center, elderly daycare center, rehabilitation facility, ventilated care center, and home health monitoring. As a conclusion, there is a frequent visit to the emergency department for those elderly patients with chronic disease, and they also reporting difficulties in managing their medications. There is important necessity for enhancing primary care administration, preventive measure, and use of peers criteria to decrease the use of potentially inappropriate medication. The older females and those who live isolated, they are the one who commonly experiences variety and malnutrition. So that's highlight the importance of conducting nutritional assessment and implementing specific and intervention to address these issues, considering disadvantaged groups. Also, the analysis highlighted the significant deficiency in geriatric specific knowledge and training of healthcare workers. Also, to tackle the chronic problems and related quality of life issues, Gulf countries has to execute policy and practice reforms. For example, working on having some clinical protocols in geriatric medicine, improve training programs, and integration geriatric medicine within other healthcare services. As a main recommendation, we need to emphasize in development of coordination and cooperation among member states in the preventive, therapeutic, and rehabilitative geriatric medicine fields. We need to identify clinical protocols and for geriatric medicines aspect, and also we need to opening new channels with and collaboration with international experience agencies to enhance the practice of geriatric medicine in Gulf region. Thank you for your listening. If there is any question, you are more than welcome.
Thank you, Dr. Asma, for enlightening us on the geriatric population, and the recommendations you have given, I think, are very useful. Questions for Dr. Asma, please. Any questions for Dr. Asma, please? You can write it in the chat box also in case you have any question. So no questions for her? Thank you
Hopefully,
so much,
my
Dr. Asma.
exercise was concise and clear. Thank you very much for giving me this opportunity, and I wish you all the pleasant evening.
Thank you so much, Dr. Asma. Thank you for joining us. I would now request everyone, we'll resume, we are breaking off for lunch and we'll resume the sessions at 2 p.m. By time. So thanks a lot for everyone. Thanks a lot to everyone for joining in. And thanks a lot for to all the speakers who have enlightened us in these two sessions in the morning today. Thank you very much. Thanks a lot.
Welcome back, everyone, after the lunch break. Can you hear me? Okay, great. Thank you, Mr. Bari. Okay, we will start now with Miss Halima. Please unmute yourself and share your presentation. Okay, maybe Miss Halima is not around, so we will start with Dr. Barry. Yeah, go ahead, Dr.
Hi, I'm here. Greetings to everyone. You want me to show my screen while I'm talking? I will share my screen.
Mhm.
And slideshow. So I'm going to be speaking with you all today about health disparities in the environment. I am in Dallas, Texas, and much of which I will be presenting you will be U.S. work in Dallas, Texas. By training, as you can see, I'm a pediatrician and public health physician, and I've lately become very involved in looking at how environmental issues are affecting health outcomes. And while my data, what I'm presenting is really US specific, it can be applied in any place where there are health disparities and economic disparities. Just a few definitions here: equity, which is fairness and the way people are treated. Social determinants are those conditions that people live, grow, and work in, which may or may not affect health. And racism, prejudice, are the targeting of single groups in a way that affects them negatively. Disparity is a situation in which two things are not equal, but especially if that's thought to be unfair. Just a little bit about Dallas. Dallas is the worst city in the United States in neighborhood income inequity. South Dallas, the southern part of Dallas, fits as the center. There's a long center of that. We are among most the worst states in the United States on most indicators of social disparities. But on the other hand, the city of Dallas has developed and adopted an equity plan and a number of supporting efforts, including a climate plan. In 2020, therefore, Dallas developed a comprehensive environmental action plan and created a civil commission, which I'm a member of. There are 15 voting members, one from each council district, one from the mayor, and we have 6 non-voting contact experts and other citizen members and a series of subcommittees. As an example, I am the vice chair of the Committee on Health. It's a very good model and it's worked very well. The CCAP has an action plan, and within each action plan, there are a number of concrete steps and plans for achieving that with timetables. Just a little bit of U.S. history for those who may be unfamiliar. Texas was a state in which there were slaves, member of the Confederacy. They passed their first discriminatory Jim Crow laws just after the end of the Civil War. Dallas itself started in downtown Dallas, spreading, but as it grew south, it absorbed a number of subsistence farming communities called freedmen's towns. They were communities that were made up of people who were freed up as slaves. Examples are Bonton, 10th Street, Joppa, and the Bottom. In my work, I am involved in all of those. However, due to discrimination, services like sewers and paved streets were not provided until the end of segregation in the 1960s. Dallas, like other urban areas, used freeway construction to fence in minority communities along with redlining. Redlining is not selling to people of certain ethnic and racial groups based on where they live. And they use discriminatory lending policies. There's a great book called The Color of Law by Richard Rothstein that really lays out how that was done in the United States. Dallas County has a community needs survey, which is a health needs survey, which is done by Parkland Hospital. also interview data for the Parkland Center for Clinical Innovation, Communities projects. They interviewed over 15,000 low-income people, as well as pulling data from every public data source available in order to do those. The big four: food insecurity, not knowing if you can find food, affordable housing, healthcare access, and transportation. We're not going to talk much about transportation today, but we will talk about food insecurity and affordable housing and healthcare access and its effect in particular. What's food insecurity? It's a lack of consistent access to enough food for a healthy lifestyle. Hunger is the feeling of feeling uncomfortable, so it's somewhat subjective, whereas food insecurity refers to the lack of available financial resources or access to food, and that food should be healthy. We'll see that in a few minutes. Also, on the other hand, we have childhood obesity. Childhood obesity is an ongoing problem with a sort of unique connection. Ironically, many places where food security is high in the United States also have high prevalence of obesity. And that's because these food sources which are available are highly calorie rich, but highly in a way that promotes obesity. And those who feel insecure tend to overeat and to overeat the unhealthy foods which are available. Aetna, which is one of our insurance companies, looked at their healthcare costs for obesity, and their cost for children who are obese are twice as high as other children, reflecting more profound health problems. Here's some data about Dallas and food insecurity. 1 out of 6 people in North Texas are food insecure. Dallas County is seriously impacted. The rate of food insecurity in the county of Dallas is 47 times higher than the national average. 1 in every 5 children in North Texas is food secure. 1 of every 10 people in Dallas County has diabetes, and 1 out of every 5 don't have health insurance. That is one of the highest rates in the country. Actually, it's the second highest of any municipal area. Now, how does that fit with hunger? Many people have full-time jobs, but still suffer. Homeless individuals are a small portion of those, but significant. Most food insecure people do live in their own homes. 84% of households served by the group Feeding America report buying the cheapest food instead of healthy food. That's partly a function of cost, but as we'll see, it's also a function of access. And people who face food insecurity do not eat substantial nutritious foods. They eat, and they also face a lot of health problems because of that. It's a complex problem. And one of the things that we'll talk about is how it's not enough to just hunger. You really have to look at all of the 6 social determinants in the 6 pillars model that I've developed in order to really effectively address all of the items, including food insecurity. Now, this is a map of the Dallas area looking at food insecurity, and you'll notice the concentration in some areas. I particularly want you to look at the area which is at the southern end in this area where my pointer is right now, because we'll see that over and over again. The area that is right over here, in where my pointer is right now, is zip code 75216. And 75216 has the second worst mortality for an African-American male of any zip code in the United States. The income in this zip code over here, where my pointer is right now, is about $75,000 a year. I take it back, $275,000 a year less than 5 miles away. And 5 miles away in 75232, the life expectancy is 92 years. It's 17 years greater than that in 75216. And notice again the concentration and that lack of a vehicle clearly goes between the two freeways that you see on this part of the pointer. In this part of the pointer, they are locked. We're locked in by the freeways, and in that area where the pointer is, in some places, if you don't have a vehicle, and 43% of the population in that area does not have daily access to a vehicle, you would have a 45-minute public transportation commute one way to a grocery store. And so clearly buying the unhealthy food that's available in some of what are called convenience stores is much, much easier. Now we're going to shift and we're going to talk about asthma and poor housing. So food insecurity is problem number one. Problem number two is the effect of poor housing on children. The Children's Hospital of Dallas Alliance identified that Dallas City Housing Code had not been updated in 20 years. Dallas Area Interfaith, an organization that I work with in the area of Bachman Lake, right north of Love Field Airport in Dallas, identified upsaving and substandard housing as a concern. We did a walking tour of housing, and then we updated the code by a 13-1 vote. The one dissenter said that we needed stricter changes. One in 10 white children in Dallas has asthma, and Black children, the rate is 1 in 8. We will see some of the reasons for that. It's a major cause of disparity. The inner city asthma study done in the 1990s elevated that. Dallas was one of the 8 cities in that study. The Parkland Community Health Plan, which is a Medicaid insurance health plan, identified that 13% of the children, about 26,000 children, had asthma. And the average child at the time when they initiated their highly successful program had almost one emergency visit or visit to the hospital for asthma per year. Asthma contributes to healthcare costs, $700 for him. And it's key to understand evidence moisture as a root cause. That inner city asthma study specifically pointed to excess moisture as a cause. One study by Dr. Peyton Eggleston showed that cockroach was the predominant allergen in dwellings in the inner city areas, in contrast to the predominant allergen in suburban and more wealthy areas where airborne pollens and dust mite. But in the inner city housing study, they showed that mold and cockroach were the predominant allergens. Mold and cockroach, as well as bed bugs, need moisture in which to survive. And in the second study, looking specifically at cockroach in the inner city asthma study, Dallas had the highest indoor air humidity, over 58%. Nobody was about 30%. Dallas was third in cockroach sensitivity. Moisture-related biologic growth, thus, is the root cause of allergen sensitivity in Dallas inner city housing. Some of the work we've done recently also looks at the effect of outdoor air quality, specifically related to plants which emit particulate matter, PM 2.5, those small particulate matter that can get down into the lungs. Later on, we will look very closely at that factor. Parkland Health Plan, which is the Medicaid HMO, had about 225,000 members when I was a medical rector back in the starting in 2003 and extending until 4 years ago. 92% were under the age of 18 because of the restrictive practices of Texas Medicaid in terms of providing health insurance to low income, those in low families. Parkland began home visits in 2006, program I started. We then developed a predictive model about 15 years ago. 10 years ago. We developed 12. We developed a predictive model that predicted which children with asthma would have an ER visit to be admitted to the hospital with 70% accurate. This is a creative use of artificial intelligence, particularly the machine learning part of use of artificial intelligence was used to produce that model. Just parenthetically, after that, we then developed a model that was highly predictive of predicting preterm birth. We deployed the model to our primary care providers. We cut our ER visits by over 30%, hospital admissions by over 50%, reduced our asthma costs by over $6 million, sustained those results for 8 years. This is a highly successful intervention. We began to do some things. We also, PCHB medical director, by the way, was me. We geomapped the children in the 2 highest risk categories and identified 8 zip codes with more than 50 members, we call them, of the health plan. These were children at the highest risk categories. There were 3 zip codes of the 8 zip codes in Dallas with over 10% of the total population. The highest being 13.3 in, guess what? 75216 zip code. Mesquite zip code had 1.7%. So what's afoot here? What we found out by doing focus groups and looking at the areas was that, and looking at the intercity asthma study, is that the excess moisture-driven allergens, specifically to cockroach and mold in the apartments, was driving much of the disparity. Within that area, there's disparity that's driven by exposure to pollution that even further exacerbates the problem we'll see in a few minutes. So here's your asthma severity by zip code. Notice 75216 there, right in the middle, 75217, 75211. And I hope you can see the percentages over to the right. Those 3 areas, 16, 17, and 11, all have over 10% of the total members of the health plan in the 2 highest risk categories. So in conjunction with the regional office, we developed and implemented an environmental assessment plan as part of our asthma home visits. These were done by respiratory therapists, not by environmental scientists. And in the first 125 homes we visited, over 80% of those had code violations of that Dallas housing code that would affect a child's asthma. So clearly we have a driving root cause here. Our next steps, which we did not get to implement before I left the health plan, what we found was that parents were reluctant to report because of fear of retaliation by the landlords. Parenthetically, this week, I am dealing with a case of retaliation by a particular slumlord in the Bachman Lake area, evicting the most vocal member of the tenants who is speaking out and reporting violations to the city, so that fear is a substantial fear. We have other cases where people have arbitrarily had their their rents raised, or have been otherwise retaliated against to force them out, and of the apartments to seek other housing when they reported. The next step we were going to do was to geomap down to the address and block level and have code enforcement inspect selectively in areas with high concentration of high-risk asthmatics. That work remains yet to be done. So remember I talked before about looking at the idea of all of the social determinants and trying to have programs that have multiple ones. So food insecurity, and this is a model, the 6 pillars model, that I developed in order to help develop programs in my new work with Lachman Community Development and Consulting. Food insecurity, safe and affordable housing, healthcare access, and there's some solutions there, transportations, including the use of rideshare, it should say. Economic development, education go hand in hand. And so economic development, and finally, as a result of our experience with with COVID, lead, and some of the effects of air pollution, biosafety. In terms of where we are, as an example, if to address food insecurity, we're developing community gardens and distribution systems, then we need to train master gardeners from the community as a way of promoting economic development. Also, education programs on food insecurity in the schools are an example of educational development. Now, what's going on right now, even as a result of these changes? We have conglomerates of landlords mostly from the East and West Coast, flipping complexes, allowing aging properties to deteriorate, avoiding enforcement as long as they can, raising rents, and then creating health and public safety hazards due to property. And that's it. We need solutions for communities. Here's an example of some of our solutions. Affordable housing in a neighborhood called The Bottom. Largely developed, this model has been largely developed by the visionary Alonzo Harris, who himself grew up in a housing project in South Dallas. Bonton Farms is one of those traditional communities, and they kept the farm, but they're now developing tiny villages for the homeless. So nutritious food, and this is a key factor. And to that, this is a garden at a church, Freedom Missionary Baptist Church. Looks pretty good, huh? Restorative Farms at Hatcher Station is a seedling farm. They also have a solar training facility there to train people as solar installers to help with some of our energy problems. This is the Joppy Mama Farm, and you'll notice me standing with my fellow members of the Environmental Commission and staff from the city. The woman who is the third from the right is the real leader. To her left is Catherine Bazan, who is the chairperson of the Environmental Commission. Paradise Missionary Baptist Church has a unique program. They have education classes, but you'll notice the school children on the right, they have a program with the local public school and middle school, and they are teaching the biology, good eating, preparation of the food, and gardening at the same time as part of the curriculum at the school. Temple Shalom is in North Dallas, in a very affluent area. I belong there, And waiting to see if I'm in. I guess I was taking those pictures, so I'm not in either of them. I'm out there virtually every Sunday. It's one of the few places in the world that you can sling dirt, and it's a good thing. You can see the beds that we've developed there. We have 64 of those, and we are on the road to producing 13,000 pounds of produce a year, and we're distributing that through partnerships with a number of different organizations. Here's the 4 Down Food Warehouse and the skate park they've developed. And what they identified is that the gardens, one will have too much okra but need beans, and one will have too much bean and need okra. So the idea of having distribution systems that link us all together is a key part of that development. Now let's shift and talk about particulate matter and health outcomes. As you can see, particulate matter has been shown to cause a wealth of health problems. And we'll see about PM 2.5 to understand it in a minute or two. But not on that list, there should be one more bullet point, and that is gastrointestinal cancer. Those have all been linked to PM 2.5, or the smallest particulates. Here's some statistics. So clearly there are health disparities by ethnic group, according to the New England Journal of Medicine. Particulate pollution is responsible for 150,000 cases of type 2 diabetes in the United States. It shows you, notice that a human hair is 50 to 70 is 25, basically 20 times bigger or bigger than one of a PM 2.5 particle. And the reason PM 2.5 particles are particularly harmful is that they can not only get all the way down into the lungs and the alveoli, but they can also penetrate into the bloodstream to cause their mischief. We did some work when we were fighting a polluting batch plant, and this shows the effect of PM 2.5. The zip code, which is the zip code that this particular that the particular plant we were testifying against. By the way, unfortunately, the Texas Environmental Commission just granted their permit. We'll be appealing that, and if we do not win the appeal, we will be taking direct action to block the operations of that plant. We will put that plant out of business and save the people in the area. But we looked at Parkland, as a result of some of the work we started, created a pediatric asthma vulnerability index. The zip code that that particular plant is in has the second worst asthma vulnerability of any zip code in Dallas County. There's 65 zip codes in Dallas County. The census tract is in the bottom in the worst 3%. So there's something going on in that area. By the way, if you're sitting in the batch plant and you cross the street, you are in zip code 75216, again, accentuating the disparities. And so outdoor air quality is also a factor. And here's the data shown again. And notice again our concentration in the area in South Dallas in asthma vulnerability. So what are the sources of particulate outdoor matter? Concrete, batch plants, and shingle plants. We're also combating a shingle plant, trying to put a shingle plant out of business that's in West Dallas, in the Singleton neighborhood. There are something like 32 of these identified pollution sources that the city of Dallas identified, and all of them are in low-income areas with concentrations in South and West Dallas. Gasoline-powered lawn equipment contributes 9% to the greenhouse gases in Dallas County, and motor vehicles are also a potent source of PM 2.5. The rental housing record we've already talked about. 12 of the 14 properties are owned by groups outside Dallas. The rents are being inflated. The properties are not properly maintained. When code enforcement intervenes, the properties are sold to another real estate group and they have to start over. Joy Reid from MSNBC has really done an expose that this property flipping is going on nationally. The moisture we've talked about and the particulates. We did a survey in the Bachman Lake area of some housing complexes recently with Dr. David Larry from UTD. And what we did was took portable computers and measured the air quality inside and outside the apartments. In most dwellings, your indoor air quality is better than your outdoor air quality. Because the filters on the furnaces and so on do catch a lot of the pollutants. They're not as effective as, say, electrostatic precipitator, but they do catch some of the harmful substances. In this case, our levels were 2 to 5 times, were 2 to 15 times higher in the apartments in every single room that we surveyed. So we have a public nuisance going on here. Public nuisance means the city should be able to take over the property, fix it up, and abate the public nuisance. One of the difficulties that we will face in all sorts of areas politically is the difference between the authorities of different levels and parts of the government, and that's an issue which needs to be addressed. Now, this is the Kendall Villas apartments, just a few vignettes to speak. Notice the ceilings collapsing on the right, mold, and when you look at mold, the vent, it should be vent, not vent, has just been painted over, so you can see the mold through the paint. So they're not abating the problem, they're just putting a cosmetic layer on it. And this is under a sink. You can see the black is common mold, not black mold. Most molds, even if they're black, are common molds, and that contributes to the exposure to allergens. The particular child in the apartment on the left, the family was one of the ones that was harassed into moving out. That child had an evaluation by their doctor saying that their problems were directly caused by the conditions in the apartments. Now we're going to shift and we're going to look at another factor. Cancer Alley is the 85-mile stretch of the Mississippi River between Baton Rouge and Louisiana. So it isn't just Dallas. It's one of the most heavily polluted areas in the United States. Chemical plants and production of plastic. Plastic production is a particular source, and it puts lifetime chemicals into the water. So we desperately need to recycle plastic. In the 7 Cancer Alley parish, there are more than parishes like a county. There are more than 200 facilities that emit chemicals into the air and water. Preserve, Louisiana, which is in the Delta, has the highest cancer risk in the United States at 50 times the national average. To show that it's not just in Louisiana and Dallas that we're facing this, in Laurel, Mississippi, the risk of cancer, 39 times the federally cancer pollution is 39 times higher than the federally acceptable level. And that has to do with a high-tech management facility. What can be done? Advocating for code enforcement and changes in local government media. Identifying and develop organizations that foster food insecurity and housing solutions. Promoting and encouraging urban agriculture and improving food distribution. Recycling and using plastic and advocate for the reduction of plastic waste. joining efforts to address initiatives for environmental health equity, promoting and encouraging the use of solar wind energy, and developing local food waste programs through composting. I would add to that we are taking legal action. We are going to be pursuing action against the landlords in the Bachman Lake area, and I am advocating civil liability suits for the health damage cost. I was a part of the early work which led to are getting lead paint off walls in the United States. And the landlords were always better than we were until somebody got the idea of bringing a civil lawsuit for the health damage done to a child in one of the apartments. He won a large award, won 2 or 3 more, and every slumlord in the country had their hand raised saying, do my apartments first. We need vigorous action in this case in order to overcome. I thank you for your time. I don't know if the format or if we have time for questions, but I'm open for questions. And if anybody wants to get a hold of me, you can get my contact information. I was on one of the first slides through the UCG conferences. I'd be happy to hear from all of you to collaborate on both national and international efforts so that we can produce positive change for the health of all of the people in our areas, particularly those who are disadvantaged. Thank you.
Thank you, Dr. Barry Lackman. It must be great efforts has been made. Is there anyone has any question to Dr. Barry, please?
Well, if there are no questions, I was either very good or very bad. Just for reference, it's 5:30 a.m. in the U.S., so I'm joining you very early. I hope you're all enjoying the conference. And later today, I will be talking about to a lawyer about our efforts to abate one of the leaders of our effort in the Kendall Villas apartments that I showed you the picture of as a payback or a retaliation. The landlords are refusing to renew her lease on her apartment after she the civil code that we talked about specifically forbids that, makes it a crime. So we'll be pursuing that with the city, but we may also be pursuing civil litigation on behalf of the child whose asthma was caused by the conditions in the apartment. Hopefully we can get the attention of the landlord and make the family well off for the rest of their lives.
Yeah, thank you, Dr. Barry. Actually, your presentation is very informative. So if no questions for Dr. Barry, so we can move to Ms. Marwa Darwish Al-Nabhani from Oman. Thank you, Dr. Barry.
Thank you.
Ms. Marwa, please, you can share your screen and present your presentation now.
Yes, Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam wa rahmatullah.
So you can hear me by this?
Yes, your voice is clear, but we are waiting for your presentation.
Okay, sure. So good afternoon to all. This is Marwa Al-Nabhani from the Sultanate of Oman. I'm working for the Ministry of Health, and I am so glad of being there with you today, sharing my project. So I will start over my presentation. telenursing in Oman, a transform to sustainable health. And here I am focused.
Sorry for interrupt, Ms. Marwa. We still cannot see your presentation.
Already. I'm sharing it actually. But it's clear with me actually, but I'm not sure why it's not there yet.
You can share your main screen instead of the PowerPoint.
Sorry, where from I can do that? Show good.
If you cannot share it, we can share it for you.
Okay, yes, please. So better to save time. Yeah, I would
Okay.
appreciate that. Oh yeah, thank you. So my topic is telenursing in Oman, a transform to sustainable health. And here I am focusing only on two basic nursing services that are patient monitoring and health education. And that is as part of health promotion. As technology revolution continues to emerge, particularly in healthcare system, as in telehealth, telemedicine, and in particular here in telenursing. All of these healthcare innovative technologies have been widely recognized and used in wide ranges recently. So to know what is telenursing, in general, it refers to the use of innovative information technology and telecommunication system to provide nursing care remotely. And the evidence show that telenursing brought into practice primarily in 1974, when the nurse called Marie Quinn provided remote nursing care to patients who were at Logan Airport in the USA. So since then, telenursing has been used widely around the globe, and it has been started successfully in many different countries as well. And specifically, if it is maintaining the main 4 principles of sustainable clinical practice as it is shown. So we go through these 4 principles. The first one is prevention. And by the way, in this project, I was careful that to maintain all of these principles of maintaining a sustainable clinical practice into this study as well. So the first one is prevention of diseases. In order to maintain a sustainable clinical practice, then you need to tackle preventing diseases. So, and that is by tackling the causes of illnesses and inequalities. And I can share with you a research finding which reported that yearly, the non-communicable diseases are causing 17 million premature deaths yearly around the world. And that is really a huge number. So telenursing here can tackle this problem through health promotion and providing health education sessions as well. Going to the second principle, it is patient self-care. And that is and that is to maintain the concept that health is the responsibility of all. Since health is the right for all, then basically every patient has to be a part or a basic part of his own health self-care and be part as well in his healthcare management. And then the third principle is lean service delivery. So by using telenursing services, we will be able to maintain lean service delivery and preventing unnecessary activities that the patient might, for example, the patient might wait for his turn for at least an hour, if not more than that. And the last principle is transportation. Of course, transportation is part of air pollution. And here, since there is no need for the patient to transport to the healthcare institution in person, then there will be a less carbon emission and driving the whole environment into sustainability. And here in this slide, I can, maybe it's blurred and sorry for that, but I conclude what is there in this slide. Actually, in Oman, we have a famous strategic plan. It's Oman Vision 2040. And we have a lot of priorities there. Part of these priorities is health priority. And our main goal to achieve this health priority is to maintain or to achieve the concept to all of citizens that health is the responsibility of all. So the aim is to have all citizens to be part of own health self-care. Okay, can we move? To the other slide, please. Okay, here we can see in this graph, there is a significant increase in telehealth initiatives around the world. As per WHO region, in this figure, it's clear that there is an increase in telehealth initiatives, in particular to nursing services, as in remote patient monitoring. You can see that it has been dramatically increased into practice. For example, Africa, America, and Europe. Now, in specific to my project, excuse me, can I have the control to move the slides, or it couldn't be? Maybe the previous one. Excuse me. No, to the previous. The previous, yes, here. Yes, no. Why telenursing? Sorry. So the previous slide, please. Yeah. So why did I choose telenursing as a project to be studied in Oman? One of the main reasons is that nursing services are still delivered in person in all healthcare institutions in Oman. And I believe that is still the same in a lot of areas around the world. So I find it a good start to practice telehealth here in Oman. Locally, I did an annual patient visit statistics to emergency room and to the outpatient clinic during the COVID lockdown between 2020 and 2021. There was a remarkable reduction in the visit to emergency room and general practice clinics during the lockdown as compared to the same period when the lockdown was released. And it was almost about 10,000 visits difference between the two periods. When I went deep into investigating the reason on this reduction, I found out that the patients from the respondents specifically were able to manage their illness or minor illnesses here at home with some medical advices, which were received via mobile communication. And the second reason is the population is growing and a lot of healthcare infrastructures need to be extended to accommodate all of healthcare needs of the population. So telenursing services here would reduce the financial burden of our healthcare system. I found also telenursing is a chance to involve the current industrial revolution and accelerating technologies. And that is to improve healthcare system, particularly in nursing service. Further, globally, nursing is there is still a focused attention on acute care rather than on prevention. So since acute care services need high financial expenditures, then the focus to preventative health can be a better solution and saving a lot of costs instead. And finally, nursing profession is, of course, found one of the most professions that suffers from shortages. Therefore, if we can introduce telenursing here in Oman, this will reduce the pressure of our healthcare institutions and the provided care in hospital. We will have a less pressure over the nurses there who are providing care for example, the admitted cases or any other cases that need an in-person hospital visit. They will be able to provide a focused and quality care. So moving to the significance of having telenursing service in Oman, I found it significant to examine the applicability of starting telenursing in Oman because the patient will have an easy access. So healthcare services will be brought closer to the patient and they will be directly involved in their self-healthcare management and as well promoting their healthy and sustainable life. Further, healthcare cost reduction, as global healthcare cost is in a continuous rise, then telenursing service would be part in reducing this burden, as I said in the previous slide. For example, while we are doing a virtual patient monitoring for minor illnesses, then the community wellness would be raised, and that is leading to community health sustainability, hopefully. And then the pressure of our healthcare institution, including all types of procedures, are reduced, then this is going to save a lot of money. Further, nurse-to-patient telecommunication with no in-person crowded clinic visits. And this service will maintain patients' privacy and patient care plan is properly followed. And this is leading to better patient outcomes and finally, it will reduce the risk of nosocomial infection. We can see here this graph. There is a little and simple comparison between triaging in person in the healthcare institution, and the other side is teletriaging is provided remotely. Simply in this graph, you will see that when there is an in-person triaging, it's shown here to be crowded as a result maybe of the prolonged waiting time and because of the categorizing system, or even because of shortage of staffing in the clinical area. However, on the other side, of this image. If this whole process is done virtually through telenursing, this issue might be solved. Okay, the graph here is showing a very interesting findings of the benefits of providing remote monitoring for patients. Here the graph is showing a clear reduction in mortality rates in about 45%, and the emergency room visits have been down to 15%, and the emergency admissions is reduced in 20%, as well as the total cost per patient is down to 8%. And now, one more significance for introducing telenursing in Oman is to promote preventative health, and that is through providing an ongoing health promotion programs, and by emphasizing health sustainability of the whole population, and that is through providing possibly telehealth education sessions to maintain sustainable community health. Okay, now in specific to my research here, named specifically telenursing service in Oman, telehealth nursing primary healthcare need analysis. So I have done a need analysis, and the objectives of my research were to examine the acceptance of telenursing service care, self-care, management for minor illnesses, and then to examine patients' need for health promotion programs, and that is to be conducted telenursing mode. And the methodology that I used was cross-sectional study using self-administered survey that took place in a general practice clinic. And the finding out of this study, actually, I found a very interesting results, as it's shown here that 73.8% of the patients agreed that not all cases need in-person healthcare institution visits, and a percentage of 97.7% says that certain medical cases only need medical advices on how to treat oneself or one's family at home, which can be obtained via telenursing virtually. And further, I found out that 90.5% of the respondents reported high need for health promotion sessions, and they preferred it to be in virtual manner, and that is because they believe, of course, that is prevention is always better than cure. Now, telenursing, just like any other telehealth technologies, might face some challenges, and these are some of these challenges: technology barriers, technology-based programs. So nurse or patients might encounter some technical problems related to video conferencing, connectivity, or device compatibility, and etc. And then insurance coverage issues. Telehealth is payment-based, as in telenursing service as well. So some insurance coverage issues are faced by patients. And then regulatory obstacles. There are multiple legal, ethical, and licensing considerations to start telenursing service and telehealth as a whole virtual type of care. Also, telenursing might not be applicable in all situations, because certain medical conditions and injuries might require in-person hospital visits to further do diagnostic interventions and need face-to-face care. Therefore, telenursing might not be beneficial for them at this point. So thank you. That's all about my presentation.
Thank you, Ms. Marwa, for this informative presentation. Is there anyone has any question to Ms. Marwa, please? So thank you, Ms. Marwa, for your presentation. And I will move now to Ms. Devon Brass with her topic, International Communication in an English-speaking environment. Please share your screen and show your presentation, Ms. Devon.
Okay, thank you so much. Can you hear and see me?
Yeah, clearly.
Awesome. Okay, thank you. Good morning, everyone. Good afternoon, good evening. My name is Devon Bruce, and I am the founder of English Communication Academy. And today I'm going to be talking about how to overcome intercultural communication challenges in English-speaking healthcare settings. Over the next 25 minutes, I'm going to first talk about the significance or the importance of having intercultural communication talks. Then I'm going to talk about the common barriers or challenges of speaking to people from different cultures, along with some actionable solutions to those problems. And then finally, I will take some questions from the audience. But before I actually begin, I want to formally introduce myself. Like I said, I am the founder of English Communication Academy, and we help non-native English-speaking medical professionals communicate effectively with their patients, colleagues, and staff. So we don't teach them English because they use it every day in the medical field. However, there is a language gap between the textbook English that they know and the everyday working man's English that they need in order to communicate effectively. So for example, we have a member, he's from Saudi Arabia, lives in New York, he's a surgeon, and he was getting a lot of complaints about his bedside manner, and he just could not understand why he was getting those complaints, and it was causing him a great deal of stress. He told us it was keeping him up at night. He wasn't able to fully connect with his patients, and that resulted in a lot of guilt and shame, and he felt like a failure, to be honest. Anyway, when he started working with us and he realized that we use our voice for clarity. So in English, you can say the same sentence 5 different ways and have 5 different meanings. And then he was telling us in his native language, the voice is not really used like that. So when he started understanding the power of using your voice in English and how that can directly impact your ability to communicate, then he started to understand the nuances of English, and that was able to start the journey of him being able to communicate with his patients and his staff better. So it's those types of things that we focus on, those things you just don't learn in a textbook. And it's a virtual academy, and we have members from all over the world. All right, so now that I've introduced myself and told you a little bit more about the academy, now I'm going to talk about the significance of intercultural communication in a healthcare setting. Now, I'm assuming everyone here knows what intercultural communication is, but just to be on the safe side here, I just want to quickly say what the actual definition is. And that just means that you are able to communicate with people from a different culture than yours. Just plain and simple, your ability to communicate with someone from a different culture. Now, when you're thinking about that in a healthcare setting, there's actually 4 aspects of that. I'm not going to go into full detail because I'm going to be doing more of a deep dive in each of these categories. But for right now, just something to think about. So when you're thinking about intercultural communication in a healthcare setting, the first thing that comes to mind is cultural awareness. And that just simply means that you just recognize that you are speaking to someone from a different culture. Next is verbal communication. So someone that you're speaking to could have different nuances, a different proficiency level, different communication styles that greatly varies between the different cultures. Next is cultural sensitivity, just having a level of respect and openness to someone from a different culture. And then finally, adaptability. That just means that you are open and flexible to speaking to someone from a different culture, and that may be different from yours. So just being open to adjusting if need be. All right, now that we know what intercultural communication is and thinking about it in a healthcare setting, now I'm going to talk about the actual barriers that you see in English-speaking medical environments. So the very first thing that comes to mind for a lot of people is just the language barrier. If there's a language barrier in a healthcare setting, that can lead to a myriad of problems, including misunderstandings, misdiagnosis, and that has a decreased patient satisfaction. And sometimes that can lead to a lowering of quality of care. I'm pretty active on LinkedIn, and also I do a lot of networking, so I meet a lot of people. And when I tell them about myself or what I do, or if someone finds my content on LinkedIn, I hear this all day, every day. Devin, I just went to the doctor and I could not understand what they were saying, or the nurse was trying to take my blood pressure and I couldn't fully understand what the instructions were, and the frustration of that. Or a medical staffing company would say, we're hearing complaints from our international staff because of poor bedside manner. So just a simple language barrier can cause all kinds of problems in healthcare. And then on a business side, that costs money. It causes the business or the hospital money because the level of time goes up, the customer satisfaction is down. So just simply having a language barrier is like that big elephant in the room that causes a lot of problems on both sides, on the patient side or on the staff side, and then on the business side as well. Next, when you're thinking about common intercultural communication challenges, the communication style can be different, meaning direct versus indirect. So for example, your culture could be very direct, meaning that they go straight to the point. They don't mince their words. They are very forward. There's no thinking about tone. It's just straight to the point. You could be speaking to someone who is from an indirect culture, meaning they're more reserved. They don't really talk about their feelings too much. They think more about the community versus the self. And if you're speaking to someone from a different culture with a different communication style, that can lead to all kinds of problems, especially misinterpretations, because someone might take it personally, even though the person that's speaking might not mean to do it that way. And that can hinder communication between everyone. Doesn't matter if it's the patient, the colleague, staff, management. Different communication styles can cause problems. Next up is cultural stereotypes and biases. This is huge. This is one of those underbelly challenges that a lot of people don't think about. Yeah, you think about language barrier because that's very overt, that's in your face, but all of us have cultural stereotypes and biases. And if those go unchecked, then that can immediately lead to mistrust. And that can cause ineffective patient-provider interactions. And in more extreme cases, that can lead to compromising patient care and outcomes. For example, a few years ago, when I was still an English coach, I had a 10-week program for doctors to help them with their English. And I had a client from an English, a European country. I'm not going to say which European country it is, but he did have, we were doing some role plays, and we were doing some role plays, and we started talking about some of the types of patients that he has. Anyway, he was going on and on about how he hates people from Africa and how they were ruining his country, and he just doesn't like having them as patients. And I just thought that was really jarring to hear. And so I told him, I said, well, as someone of African descent, that's pretty offensive. And he said, why is that offensive to you? That's different. And I said, how is that different? And he said, well, you're American. And I just thought that was so interesting to hear and fascinating as well, because that was the first time I ever heard someone differentiate me from African versus, you know, being Black in America or just from America. And so anyway, I asked him a question. I said, so if I walked into your office and I was a new patient of yours, would you know that I was American initially? And he would say, no, I would just assume that you were African. And I said, so how would you know? And he said, well, I would need to hear you speak first. So I said, so your quality of care would change because of my American accent? And then that's when the light bulb came on for him. He said, oh my gosh, I did not realize what I was doing. And then he started becoming apologetic. And I just told him it's okay, you know, because if you're not fully aware of it, like I said a few slides ago, then it can be an issue. So anyway, when you have cultural biases like that, it can cause direct issues when it comes to patient care. Next up, and when it comes to the challenges of intercultural communication, is deferring cultural norms and values. So if you are one culture and you are speaking to another culture and it's the exact opposite of yours, then that can cause a lot of impacts when it comes to just interacting with them and the delivery of care. So another example of this, back when I was still an English coach and I was taking on individual clients, I had a doctor from a Middle Eastern country, and I'm not going to say which country, just like the other example, but he was moving to the US. He got a job as a doctor in LA, and so we were working on his communication before he moved. Well, anyway, one day he logged in and he was acting really nervous, and I could just tell that something was off. And so I asked him, I said, what's going on? Because we had a really good rapport, you know, we laughed a lot, you know, it was just really good times when we were working together. But this, when he logged in, it was very different. And I said, what's going on? And he said, Devin, I really need to ask you a question, but I don't know how to ask you this because I'm afraid that I'm going to offend you. And I said, this is a safe space, because when I was a coach, that was very important to me, making sure that people felt safe in our spaces. And I really make sure that with the academy as well, people feel safe to be open to communicate, because that's how you improve it. So once he felt comfortable, he just started talking. He said, okay, Devin, you know that I am moving to LA, and I just found out that my boss and my boss's boss are both women. And I am from a very remote village in my country initially, and I am a very traditional man. And where I come from, especially in my small village, men have their place and women have their place. So the fact that I'm going to have two women telling me what to do, it's really hard for me to accept that, to understand that. However, I know that the American culture is very different from mine. So I need your help with how to become more comfortable with that. I don't know what to do. And the very first thing I told him was that I'm not offended at all. I actually thanked him because his level of awareness was there. He was open to hearing different views about it. So I'm not going to go into detail about some of the things that I told him, but just having that level of awareness of a completely different culture than yours. If you don't have that, and it is a big challenge, that can lead to all different kinds of issues when you're trying to interact with either a patient or a colleague or some member of management. All right, so now I'm going to just quickly talk about some things to how to overcome these common barriers in English-speaking medical settings. So the very first thing when you're trying to overcome these challenges in healthcare is just to be receptive, just like my former client from one of the Middle Eastern countries. If you are open to just speaking to a different culture, or if you're just being receptive to the idea of it, that just automatically allows you to better understand other people's unique cultural needs and perspectives. So, but even before, improving your English or anything like that, if you are receptive to it, then that's half the battle right there. Next, if there is a direct language barrier, using plain language is key. One of the things that I hear a lot, especially over the years, is that sometimes people think, this is a huge myth, that if you use these big, fancy, million-dollar words, that you come across as more fluent in English, and that's not the case at all. We speak in pretty plain language holistically. And so if you are trying to communicate with someone and there is a language barrier, especially on both sides, so just simplify the jargon, use clear, straightforward language just to ensure that people understand what you're saying. Next, to overcome some challenges is to practice active listening. Oftentimes when people think about these intercultural challenges, people think about the speaking part, but active listening is just as important when it comes to speaking with someone from a different culture, because when you're actively listening, you are able to fully understand them, you're concentrating on what they're saying, you're able to respond better. And so even if there is a language barrier, especially dealing with patients, if they can tell that you're actively listening, they will feel seen, they will feel heard, and that language barrier is not going to be nearly as huge. And then finally, just respecting nonverbal cues. Some cultures are very nonverbal forward, others not so much. So if you are sensitive and aware of that, the likelihood of you taking things personally goes down. So if you are aware of like the gestures, the personal space, eye contact, those types of things, that will absolutely help your ability to speak with someone from a different culture. Oh, and then one more thing too, huge. Make sure you check your stereotypical beliefs and bias. It is absolutely essential that you check those, because if you don't, then it'll lead to a lot of problems. But that is key when it comes to being more open, being more respectful when you're dealing with patients or different staff from a different background than yours. And like I said, we all have them, but if you check them and if you're aware of them, then that's also half the battle as well. All right, so that is my presentation. I am open to taking questions from the audience.
Thanks a lot, Ms. Devon. This was a real thing that we all here practice every day, because the different in culture. So yeah, it's real. So anyone has any question to Ms. Devon? Okay, so since no questions, so thank you, Ms. Devon. Actually, it was very clear. And I will move now to Prof. Leila Sells with her topic, medication safety in Portuguese hospital national survey. So please, Prof. Lily, can you share your screen and share your presentation?
Good morning, everyone. Just give me 1 minute so I can try to pass my slides, please. Okay, thank you so much, because I'm not able to pass my slides, so I think that the organization can pass for me. I'm sorry about it. My name is Leila Salles. I'm a nursing professor in Portuguese Health School of Health in Lisbon. So I will present to you my work entitled Medication Safety in Portuguese Hospitals, a National Survey. Can you pass, please? So medication safety is one of the main topics that today is most complex and sensitive areas on patient safety, and one of the major areas related to adverse events that can influence the life of patients. Hospital medication systems are complex and may become more susceptible to errors if not well designed and not well analyzed. So it is essential to implement best practices, ensure safety systems and process, and promote a safety culture and a safety organizational environment. You can pass, please. So medication safety is now the third global patient safety challenge of WHO, and in Portugal is one of the strategic objectives in the National Patient Safety Plan. So we know that all medication errors are potentially avoidable and preventable if medication systems and practices are improved, including prescribing, storage, dispensing, preparation, administration, and monitoring. Can you pass, please? Regarding that, we established these three objectives for our national study. So analyze the safety of hospital medication systems in Portugal, identify the predictive factors of hospital medication system safety, and verify the relationship between hospital characteristics and the safety of hospital medication systems. You can pass. Regarding that, we established the following research question. You can pass the slide, please. That it was, how safe are hospital medication systems in Portuguese hospitals? You can pass. So methodologically, we define a correlational and cross-sectional study. The population was all the Portuguese hospitals, and the sample was composed of 95 hospitals. We use a questionnaire with 5 scales that we had construct and validate for this purpose. The data analysis was descriptive and inferential statistical measures. Regarding that, in the beginning, we had the approval by the Ethics Committee of the Portuguese Catholic University. You can pass, please. So regarding the results, the 92 0.6 of the hospitals reported that medication safety was an institutional priority, but just 50.53% of that considered that the medication safety level was just acceptable. So we have here a big problem because the major of the response are in the acceptable and weak level. You can pass, please. About the strengths, we saw that medication safety in the hospital pharmacy was the subscale with the highest overall mean. So it was the best part of the process of medication safety. And also medication safety related to the organizational environment with the second highest mean. You can pass, please. Regarding the opportunities of improvement, we saw that we have the need for more hospitals to have quality insurance systems in place and accredited across all the institution, and the need to improve patient information and education because it was the subscale with the lowest average. The need to improve safety also in prescribing medication. You can pass, please. Regarding the hospital characteristics that may influence medication safety, we had find no significant association between medication safety and hospital teaching type, as well with hospital size regarding the number of beds. But we had see a significant association in relation to the type of hospital care, the area of specialization, and the management model. So the general hospitals score better in all scales and the overall score. And also the hospitals in a public-private partnership regime ranked better in all scales and in the overall score, followed by private hospitals. So this confirmed the hypothesis that regarding the legal framework and management model having an impact on medication safety. You can pass, please. The slides. So concluding remarks of this study was a pioneering at a national level in Portugal and enable us to diagnose the situation regarding the safety of existing medication systems in hospitals, as well as the implementation of safety medication practices. It was found that not all hospitals are at the same level concerning medication safety, and that there are large national asymmetries as well as internal asymmetries between services in the same hospital or hospital center. Regarding the predictive factors, an association was found between medication safety systems, hospital structure in relation to the variables management, typology of care, safety, and teaching status, namely the legal status management model of the hospitals, public hospitals, private or public-private partnership hospitals, and also the type of hospital care, generalized or specialized. So you can pass. Thank you so much all for your time. I apologize because of my sound, but I'm in a ceremony, so I was not able to be there with you and to have better conditions to present my slides, and I'm able to respond some questions if you want to ask something. Thank you so much. Have a nice day and a good conference.
You are good. You are all good, Prof. Leila. Is there any question for Prof. Leila, please? Okay, thank you for this informative presentation, Prof. Leila. Yeah, we are happy to see you.
Thank you.
Then
Have a nice day.
You're welcome. Now I will move to Miss Halima Abdullah Al-Hamadi. we will present her recorded presentation. Okay, we will take a break, coffee break for 15 minutes. Then we will be back in 15 minutes. See you there. Welcome back, everyone, after the small break for coffee. Now we will be back with Mr. Thomas Wright. Please welcome Mr. Thomas Wright with me. Share your screen, please, and screen your presentation.
Hello, can you hear me?
Yes, go ahead.
Can you see it? Can you see my screen?
Yeah.
All right. Well, hello, everyone. My name is Thomas Wright, representing the STY Academy. My background is I'm a former American football player, played in the NFL, went to Ohio University. Currently, the owner of a telemedicine clinic and a venture capital accelerator for people in the medical industry. Personal anecdote, I have a lot of friends that are doctors. And as a former athlete, what I noticed is we kind of all been venturing into venture capital and private equity, while a lot of my doctor friends are consumed by what's going on in their work. And I feel like there are so many opportunities out there. And I know sometimes they don't know where to start. And so myself and some of my liaisons who are also former doctors that have come this way into the venture space decide to start this program. And so with that being said, we'll get started and go over a presentation. As you know, venture capital money is flowing into many different areas of healthcare, including dental care. And this has increased more than 50% increased more than 50% year over year. The influx of cash represents opportunities for both newer and more experienced practitioners. So, you know, if you're looking to retire soon, you're going to be stepping into a hot market, or you may have the easy out if you're a self-owned practice. What we do is with this presentation is aim to shed light on the need for dentists to explore these opportunities and how they can leverage their unique attributes to excel in this field. By investing in startups and or established companies, dentists can tap into vehicles for growth and diversity in their income streams. And if you're currently working and you make a right move, you can have your money working for you, while you're, on your trajectory in your own personal career. So our medical doctor venture capital accelerator program is designed specifically to educate and empower dentists and doctors in the realm of investing through a comprehensive curriculum. We provide the necessary knowledge and skills to navigate the world of venture capital. The program emphasizes the importance of good credit, high income, discipline, and intelligence as key factors that can help dentists offset student debt, overcome their fears associated with investing. So data demonstrates the potential benefits of dentists engaging in venture capital and angel investing. By diversifying their investments, dentists can generate additional income and build wealth beyond their dental practice. Successful investments can provide the financial security, allowing to pay off student debt, more efficiently alleviate financial concerns, as well as build generational wealth opportunities. You have the potential for high returns. Venture capital investments have the potential for significant returns on investment. By investing in early stage capital, promising growth prospects can participate in the success of innovative and potentially earn substantially. I think if you're looking specifically something that you're familiar with, like the med tech space, as somebody currently practicing, what I firmly believe is that you should be able to spot winners, right? Things that can clearly disrupt or help impact heavily the industry you're in and beyond, and use that to also have instincts. So one of the things about investments is instincts. Many people look at 10 deals and invest in one, 100 deals and invest in three, 30 deals and invest in two, or whatever your taste is, whether it's low risk or you have the opportunity to take more risk. What you can do is use your instincts in this position. Network and collaboration opportunities. Venture capital investing often involves networking with entrepreneurs, industry experts, and fellow investors. Dentists who engage in venture capital can expand their professional network, learn from experienced individuals, and potentially collaborate on future projects or partnerships. An example could be this conference. So the people who attended this conference have seen people like myself pitching for days now. Within that, you have to think about how many winners have been seen, how many winners have stepped to the podium and put something in front of, the greater conference, not only to advance the industry from a practice position, but how many of these people or these companies could have taken an injection of capital and brought, significant returns in the future. And that's kind of what we're talking about. We mean networking and, adding, I'm not going to say adding a purpose, but giving another purpose or meaning in these exchanges that you and people like myself have moving forward. You can have support for dental startups. By investing in dental startups, dentists can support the growth and development of innovative companies within their industry. This can contribute to the advancement of dental care, the introduction of new treatment options, and the overall importance of oral health outcomes. Kind of going back to what I said, being able to spot winners. Most companies struggle with the initial investment, getting that early stage capital. You can be an investor at different stages. Some people come in early. Some people like to wait and support companies that they know are already making money. But if you guys decide to, like I said, if you spot a winner or you see something that you firmly believe in, you have the ability to use your success in your position to become a member of that company, and you can use your position in the industry to help that company succeed. Meaning, examples could be introductions, putting them with people in your network that can make them succeed, point them in the right direction of places to go, people to talk to, and ways to implement or adjustments to make to their product or their services to ensure that they're successfully adopted. And that goes into the final thing, which is access to cutting edge technology, which again just goes to what we were just talking about. You have that opportunity to turn these conversations, these things that you see, and use your instincts, like I said, to spot winners. So people outside the space are only going to be concerned with the money aspect or what it sounds like. And once again, all humans, we make decisions based off feelings, and we typically use rationale and facts and everything to justify those. But most people just go off the feel that they have and they do their own research, and experience is always the best teacher. So with your experience and your position in the industry, you'll be able to leverage that as quote unquote instincts that it'll take to spot a winner. So how do you attract the attention and fortune of venture capital? So you start with a clearly defined end goal. Establishing a specific end goal is crucial for any practice owner, as it provides a clear direction and purpose. Avoid reluctance. Many practice owners are hesitant to articulate their goals due to fear of restriction, but having defined goals is essential for success. So I think that targeting doctors in this space is good, because this is someone who had a clearly defined end goal, a lot of times from high school, and then other times maybe at the college thinking of something else to make that commitment that it takes can only come from someone who can see the big picture and can work themselves, backwards from the finish line to where they are when they start. Venture capital firms aim to make money and evaluate opportunities based on potential success, which can offer valuable insights for setting and pursuing goals in your practice. So once again, it's basically instinct. So I know venture capital has both a mysterious mystique about it, and there is a process, but once again, it really comes down to instincts and your ability to spot a winner just as good or better than the people around you. So if 5 of us are sitting around listening to one person talk, who can see clearly what's being presented to them, while the other 3 people or 4 people, walk away. Who's that one person is going to approach them at the end? It's like, no, I see clearly what you're doing. This will work. Let's figure that out. Set retirement goals. List your desired retirement age, ideal annual income at retirement, and the amount of time you want to spend in the office each week leading up to retirement. Prioritize your goals. Rank your goals in order of importance to create a clear hierarchy of priorities and ensure focused efforts. Accountability and coordination. Use your defined goals as a benchmark for evaluating opportunities and coordinating efforts while holding yourself accountable to stay on track towards achieving them. Once again, this is, y'all think you can even be here or in your profession if you didn't already know to do that. So what we're talking about is just transferring the skills you already have into a different space that could benefit you in the long term as you doing what you're doing anyway, which is advancing your career and growing inside your profession. Like I said, I think being here is the first step for people who are just like what has been described. So we'll talk about people near retirement. For dentists poised to retire, not taking into consideration strategic positioning for the exit strategy from the clinic, the investment will likely just eat into the 30 hours allotted clinical hours without much time to realize the reward. You must stay true to your goals. For dentists near retirement, the evaluation of an investment system should consider the limited time remaining to benefit from the technology, the high upfront costs and time required to learn and implement the system may not be justified if you're only a few years from retirement. The investment could consume valuable clinical hours without providing sufficient time to realize significant returns. So you must evaluate where you are in your career and what you're looking for in those goals. That's why we suggested having clearly defined goals to begin with, because there's a risk involved in all investments. I think that my experience with people that I know in these professions, a lot of times there is a level of being risk averse. Actually, most investors themselves are risk averse. They look to de-risk. So that's what all the process and the questions and all these different things are why they only make 3 investments a year. Essentially, everybody's looking to de-risk and make it close to what they believe is 100% win. And then you have some people have different strategies. What they'll do is pick an industry that they know going to win and make bets on a number of players, knowing that one of these has to work. So in a way, that's a risky strategy, but it's still de-risk because they were able to see it. They know that this specific industry or this specific product, specific service is going to take off. We can use something like AI, for an example. There's a realization that AI is definitely going to impact society for years to come. And now the challenge is who is going to be the person? What company is going to be the company? Which founder is going to be that founder? And so everybody has their own process. And so as you evaluate where you are, you have to think about where your goals are, where you are in your career, and what strategies can help you de-risk. The principles, not only does a venture capitalist have a clearly defined end goal, they also have thresholds for consideration. We've all heard of the main one, which is ROI, return on investment. If a venture capitalist is eyeing your clinic, industry standards suggest they plan on coming up on the deal by at least 35%, right? This doesn't mean that you can ignore budgeting, but it does mean that you are going to invest time and money into a second clinic, piece of equipment, new staff. You should have a calculated ROI and a plan of execution to get the numbers to pencil. So this is kind of the small adjustments if you're going into your practice with a more VC mindset as you make some of these moves outside of actually dealing with patients. What happens is you start to think about how is this going to impact everything that we have, especially in alignment with your end goal and the return on investment. All right, it's crucial to have a calculated ROI and a plan of execution when considering investments in new equipment, staff, or additional clinics. Venture capitalists prioritize ROI to ensure their investments are profitable. Similarly, dentists should analyze potential returns and have a clear strategy to achieve their financial goals. This involves careful budgeting, forecasting, tracking progress to ensure investments are financially sound. So once again, the people outside the space are only figuring out, how am I going to get my money back? Like, I think that there's a lot of sophisticated jargon and operations within the venture capital industry, but it's actually just simple. It's just like, how am I going to get my money back? I'm going to give you $100, but I want $1,000. What are you going to do to help me do that? You as the person is going to take the $100 should already thought about that before we even sit down. Everything that I was about to say, you should have either said it, or when I ask you, you should have an answer for it. And every move that you make, and knowing if you're going to accept the capital and not be the venture capitalist yourself, should be on with that mindset. Like, look, I'm going out here and get $100 from somebody. I'm bringing it back $1,000. I'm gonna keep whatever, blah, blah, blah. But every move that you make, has to align. If you are also, a family-based person who's like, hey, I really care about my people and everything, these two worlds can collide, right? So I think there is a way to do good and be a capitalist. And I think the main thing is to think it through and have a more robust decision-making wheel and strategy implementation plan in a win-win scenario. So I think anytime we think about win-wins, we can't create those if we really try in all settings. So after you define your goal, find an opportunity that you're excited about and calculate ROI. Let's use the CAD, CAM machine. Start by listing all the variables that having this machine would change with an estimate of how much would change, and ignore those it would not change. For example, administrative salaries, rent, whatever, So before you execute, remember that we're not just asking if this will make more money. We're asking if this is aligned with your goals. What other milestones do you want to achieve, and on what timeline? Will you need the capital tied up in the equipment before the break-even point? So that just kind of goes back to what we were just talking about, thinking about the win-win and seeing the bigger picture before you make any of your decisions. So I think that the apprehension is that, it might be too complicated, but I think that we're talking to people who are definitely high-level thinkers. So the complexities are something that, dentists and doctors can definitely handle. It's just about maybe taking another 30 seconds, another minute to think things through and to go through these checkpoints, before you make the decisions. And like I said, I think that people also struggle with adopting a capitalist mindset because, unchecked capitalism can have human casualties. But once again, there are ways to align the two, and that's just having a win-win thought process. So, instead of thinking solely about your investors, right, having a win-win mindset can even make you validate your investors. So as a person that's taking investment, you do have rights to choose who you accept money from, how you're going to accept money, where you're going to get the money from, and who it's coming from, right? So different investors have different goals, like we keep stating, and it's about making those align and thinking about the trickle-down effect, if that's where your mind or your heart is. So example is a new fund. The 4100 group started with an initial $35 million investment target deals towards innovation in dental and oral health. So essentially, the capital is out there. People are looking. People have turned their attention to the dental industry specifically, not only medical in general, or what they call med tech, which is also, a strong space. But here specifically in the dental industry, there are many people looking to capitalize on the advancement of the space. And I think that, when you look at it, everybody has some sort of economic stake, whether it be the landlord accepting rent, the, medical sales rep coming in and sell this equipment, they work for someone. Pretty much in a lot of ways, everybody except the patient and the doctor are in on the profit side. And these are some of the things to look for. Like I said, whether you're looking to sell your practice, because I think if you're an independent owner, any business person has to have an exit strategy. And the exit strategy is typically you're going to sell, go public, or you're going to keep it and pass it down to family or something like that. But if that's not your case, where you like, I want to do this to my last day, or I want to pass it down to the family, then highly likely you may be wanting to sell. And so you need to figure out who the players are and how the game is played. And here we go with dentists as investors. And Launch and Reap partners, co-founders Dr. Jeremy Krill and David Arena identified an untapped industry position for investment and improved care delivery, right? Krill's background includes multiple startup exits, followed by dental professional development at Quip and strategic provider innovation at Oscar Healthcare. So without, going too deep and reading this whole thing out to you, what you can see is that there are people in this space who've taken their previous expertise and aligned it with, the venture capital goals. And like I said, I think that Adept is something you're participating in passively or actively anyway. And you're either the investor or the investment. So the key goal of this was to, shed light to dentists, to become more conscious of the space they're already playing in, and to be more vocal in their participation to get a larger return on their energies. And for those who experience apprehension, may not have been able to follow this, or have always thought about this, we do have a program available. So you have people here who can help you vet these decisions, as well as share the true and tried methodology within the venture space, and how people do come up with investments, all the different terminology, all the ways that things are segmented and categorized onto this opportunity. And like I said, the core thing is, the de-risking, but there is a lot that goes involved in scouting. I think I mentioned earlier, I may not, I'm also a venture scout for venture capital, as well as being my own investor. And I'm also someone who operates startups. And I'm a part owner of a med tech startup called Zippy Care, which is basically a clinic in a box, aligned with telemedicine, where they send a nurse practitioner or a real doctor shows up, has all the tools inside like a kit, and do examinations on the spot that are, hospital equivalent right there in the kit. So I am involved in this space, and I have been watching it grow. And so you will be working with people who know what they're doing and have the connections and the network to introduce you and allow you to do the same thing by looking internally and executing. So hope everyone's having a great day. Hope you learned something. I really look forward to hearing from you soon.
Thanks a lot, Mr. Thomas Wright. I really appreciate this information that presented. Is there anyone has any question to Mr. Thomas? Please. Okay, Mr. Thomas, thanks a lot. Now I will move to Dr. Sunil from United States with a presentation titled by Transforming Patient Experience. So please go ahead, please.
Thank you so much. Can you hear me?
Yeah, sure.
Okay. Sorry, first of all, for not being there in person. I was supposed to be there actually in Dubai for a live presentation, but due to some emergency in India, I'm stuck here, and my travel back to the United States also got delayed. Anyways, I'm going to share. Let me share my screen.
Yes, please.
Hi there. Okay. So let me start with my slide presentation here. So my project that I did, first of all, let me back up. I'm the medical director for a rural hospital, which is 130-bedded hospital within a university. So our Wake Market, which we call comprising of 5 locations. The bigger one is the university with 800 plus beds. And I'm working in one of the rural hospitals here with 130 beds. And I'm the medical director there with 22 providers. And the project that we took up was RISE, which is the Rural Health Innovations and Strategies for Equity. I say it is a success story because in terms of patient experience, we've seen a lot of transformation just by doing minimal things. And also from what we have implemented during COVID as desperate measures. What I mean, we will explain, we'll go through it one by one as I move forward. So what are some of the objectives? Patient experience. What is patient experience? Why is it important? What is HCAHPS? And for people who are from the Western world, United States, and who follow the US care delivery models, you probably have heard about this HCAHPS. And the CMS, which is the Center for Medicare and Medicaid Services, is the one who's behind this HCAHPS and patient experience model. and it delivers the star ratings for all the hospitals. And there is some inclusion and exclusion criteria for this. And then we should be able to go through very briefly what is Leapfrog rating for the hospital and how is it different from HCAHPS. And of course, this is the next one is a very big and vast topic, which is the disparities between urban and rural health across the world, not just here in the United States or in India, in east part of the world, or in Midwest or in Middle East, everywhere. There is definitely some disparities between urban and rural health. And what is that pertaining to this patient experience that we're going to touch a little bit around that. And of course, what is Project RAISE and what did we achieve? And what were some of the innovations that evolved during the COVID era and how it helped? Not all of them, but some of them still are in existence, and how we're able to maximize their profitability by utilizing them in places like this, rural health and patients that are underserved across the world. So next slide, sorry. So HCAHPS, it stands for Hospital Consumer Assessment of Healthcare Providers, who are the doctors, providers, all the providers like nurse practitioners, physician assistants, and the systems, which is the hospital itself. So as I said, it's a national standardized survey tool which was used to measure adult inpatient perception of the quality of care. So it is more about the patient's subjective perception of the quality of care that they received when they are in the hospital. And the CMS, along with the AHRQ, which is Agency for Healthcare Research and Quality, which is another agency of the Federal Department of the United States, developed this HCAHPS survey model and the questionnaire. So there are three important goals of this HCAHPS survey. And what are the questions comprised of, and how many are they categorized into? We'll go in the as we go on in the next slides. So the three important goals of this HCAHPS survey are: number one, to create incentive to improve the quality of care. That means you give better care, you provide better care to the patients, and we incentivize you by giving more money back to your hospital, depending upon the star rating. Number two, producing comparable data on patients' perspectives. How is hospital A doing compared to hospital Z? And how is hospital X compared to hospital Y? And why are they not able to perform the same level as the other hospitals? Then number three is increasing transparency within the healthcare to make the public more accountable, which would be like, I went to this hospital, I have experienced these great things, and I went to this hospital B, which I have experienced only some. And they could have done better in this and this and this. And I provide that in the survey so that hospital B can work on improving those kind of infrastructure and what are the resources that they need to raise up to the level of hospital A. So the HCAHPS survey questions, there are 6 composite topics. One is very important, the nurse communication. Second one is doctor communication. And number 3, responsiveness of hospital staff in terms of like, hey, why is my bed not made? Or I have this issue with my room in the hospital. Can somebody come and clean my room? Something like that. And then pain management or medications. I'm in terrible pain. Can somebody come and help me right now? Communication about medications, as I just mentioned. So I have this question about my diabetic medication versus this medication which I take at home. This cholesterol medication, is it the same as the one that you're providing right now? The blood pressure right now is so and so. I'm taking this medication at home right at 6 o'clock in the morning. Can somebody do that in the morning every day when I'm in the hospital? And finally, the discharge information. So I'm going to go to my next. I'm going to show you, I'm going to show you the HCAHPS survey questions very briefly. I'm not going to go through all the details. I just want to show you how the HCAHPS survey looks like and how many questions are there. So there are 29 questions divided into 6 main domains and composites, as we just discussed. So the first one is the care from the nurses. So example, during your hospital stay, how often did nurses listen carefully to you? You can say never, sometimes, usually, and always. I know this is not the best way of reflecting your experience in the hospital, but this is the best they could come up with. And then your care from the doctors, your experiences in the hospital environment. When you left the hospital, did somebody reach out to you, or did you go directly to your home, or did somebody another hospital? Do you have to go because you're not happy with this particular hospital? And then finally, overall rating. This is very important, the overall rating. So if you're really happy, they would always want you to get 10, but I cannot really verbally say that or endorse that. CMS prohibits endorsement of any kind. So I cannot approach a patient or family and say, hey, I provided you this best care, like, any auto garage or any other car service station. I cannot go to you and say directly, hey, I provided you this best care. Can you please give me or provide me with the 10 in the survey? I cannot do that. The CMS would actually take it very seriously if you do that. And this is the one which we concentrated upon mostly in this particular project. Would you recommend this hospital to your friends and family? And finally, the understanding your care when you left the hospital. So I'm going to go back to the slides again. Right. So these are the HCAHPS survey of 29 questions. It's divided into this main 6 composites. Now, as we went through the individual questions, these are the highlights and overall rating and willingness to recommend to the hospital. This is the global items that we concentrated upon. The best ratings is always 4 and 5 stars. So the rating, the data is public. So anybody can actually get access to this data. It's out there, public. The only problem is it's at least 1.5 to 2 years behind, which is like probably the CMS is now showing you the data from 2022 or 2021 on its website because it's not a current data. So that's the only negative to this. But anyways, because of the incentives that the hospital has to receive and the other things that the CMS has to follow financially, it's always like 2 years behind. And so what is the importance of HCAHPS? It's a survey, and we're directly asking the patients. So it's a subject to patient experience. It's a standardized, consistent survey, and it is analyzed and adjusted to any kind of risk. And it's a publicly reported hospital results. And it is mainly directed towards improving the hospital quality. This is important. We are targeting the quality of care here. And the participating hospitals, all the short-term and acute care hospitals, all the hospitals and critical access hospitals, which are like 25-bed to 30-bed hospitals, which have their own regulations of how they function, who participate in the inpatient prospective payment system by the CMS. So all these are the participating hospitals. The IPPS hospitals are penalized if they don't participate. So it's a mandatory for those patients, for those hospitals. And the cancer hospitals, some of those are exempted from this, but they can participate voluntarily if they want to. This HCAHPS survey is excluded from pediatric hospitals, psychiatric hospitals for obvious reasons, and any specialty, only specialty level of care hospitals. So all the primary care, short-term acute care hospitals are the main target for this hospital rating, which comprise about, I think I would say 80% probably in the United States, and very close to that in the rest of the world. So now let's understand what leapfrog grades are and how is it related to patient scoring at subject to safety. So remember that HCAHPS targets the quality of the care provided. This leapfrog grades is directed towards the patient safety. So are the patients allowed to participate in this? No. So this is not a survey where the patients receive something in the mail and then they had to fill in like the HCAHPS. This is directly coming from the hospitals itself, and it is also publicly available data, and it is mainly targeted towards measures of safety. So for example, all the questions like, did you have a fall from any of your inpatients in the past 30 days? If yes, are there any injuries? Are there any surgical site infections? Are there any infections at all from bed sores, like skin ulcers? Are there any medication or medical errors in your hospital? Was there any death? So all the patient safety related questions, the hospitals directly had to report that, and that is what Leapfrog is. Compared to HCAHPS, Leapfrog, the data is also different in terms of it is up to date. Like it is probably the closest to the live data that we can get from any hospital. And instead of star rating, this is A, B, C, D, and F. A is the best. Of course, F is like, probably it is the worst of the hospitals. And again, that about 28 measures, including grades like preventable errors, injuries, infections, and whether hospitals have systems in place to prevent them. So this is more targeted towards the safety. And this is a real time compared to HCAHPS. And this is not annual, this is like twice annually compared to HCAHPS. So what is the purpose of the study that we did, the Project RISE I was talking about? So we're targeting the patient experience ratings. They play a major role in hospitals' CMS star rating, right? As well as the Leapfrog ratings. These publicly reported ratings can have a financial impact, either positive or negative, depending upon your star rating and your Leapfrog ratings. So we're aiming at improving our star rating, the CMS patient survey, HCAHPS, recommendation for the hospital, whether it is doing a good job or a bad job. So a unique and innovative project. I say it is a unique and innovative because nobody actually has targeted only at the HCAHPS. They have targeted the patient, the surveys like the doctor communication or nurse communication or patient safety, but nobody really targeted just overall the HCAHPS survey itself in a rural hospital. Because rural hospital is considered as one of those hospitals with limited resources, and anyways, our scores are going to be less. So who cares? Was the attitude usually among the public too. From the same community as well. If they live in the same community as a rural community, they would say, yeah, ours is a rural community. Who cares about our community? So is the attitude. That's why we had taken this specifically project in our rural hospital. So if you look at this data, these are the data from the scores from 2019 to 2022. So the communication with nurses was dropping down, the same with the hospital staff response. More so, it was a little bit stable, I would say. The providers and doctors' communication has significantly dropped down as well. Probably COVID has had some impact, but I wouldn't blame totally on COVID, how they performed after the COVID era, 21 and 22 years. So this was the composite data that we had. This particular hospital with 130-bed hospital had. Now, what are the methods in data analysis? So we performed a stringent gap analysis in the year 2022 and looked back and said, why are we doing so poorly? Why are we so bad? Are our staff doing so bad job with our services? That patients are so upset with us? Are there any other reasons why our scores are low? So we gave a high priority for the following year, which was the year 2023. And we tried to think innovatively, and we tried to change some workflows, and new workflows were implemented. And we tried to actually take those from the COVID times when we had to forcefully, desperately implement. For example, telehealth. The other one was virtual hospitalist rounding, where I sit in my home and then I round in ICU or on the inpatient side with one of the nurses actually physically pushing the cow, which is the computer on wheels, from room to room. So those are some of the strategies that we applied, and we tried to gain the max benefit out of those because they help really all the hospitals and everywhere in the world during the COVID times. And we set individual targets, and we wanted to achieve 10 to 15% better than the past 4 years. And we strictly followed the guidelines and regulations, like no endorsement was made to any patients or anybody, any families. And it was a double-blinded study, so the hospital staff wouldn't know what we're trying to do, and the patients wouldn't know either what we're trying to do or any other innovations that were new. Some of the major interventions were, we tried to utilize the AI risk models. So the first thing was, is this patient amenable for readmission if I send him home today? Will the patient come back again the next 7 days? Will it be a burden? Because the readmissions is frowned upon by the HCAHPS and the CMS as well as the HCAHPS. So it's one of the quality measures. Mortality and morbidity, inpatient falls, as I said, medication errors, prolonged hospitalization to stay. While we're really looking at the readmissions, we cannot keep the patient for more than what they should stay in the hospital too. And we tried to identify all this by using the AI risk models of how we did in the past 4 years. And by just implementing that through the EMR, electronic medical records, we should be able to get that this patient is a high risk for readmission. Yes, this patient is a high mortality risk because the patient stayed in the hospital for 30 days now. He's been in the ICU for more than 25 days. He's been vented and intubated and requiring multiple measures or multiple interventions and specialties, things like that. So the main thing then, the cheapest, was new communication boards were set up in the units. All the patient units had communication boards, and they were communicating like, I did my hourly rounding now, so time. This patient needed this right now, something like that, without even giving, because we had to strictly follow the HIPAA in maintaining the patient confidentiality. And I'm sure you might have known the white patient whiteboards that are inside the patient rooms. These are the simple things that we could use to the max, and we gain max benefit out of it. For example, I'll explain this a little bit in detail. I'm a patient in room 221, and I boarded at 6 a.m. because I was in the ER the whole night. And I seem to get no answers from my nurses or hospital doctors of what's going on with me. What were the tests that were done? What did the CT scan that was done last night in the ED showed? What am I going to do in the next 24 hours? Am I going to go home tomorrow? I'm really anxious about all these things. Am I really bad? Am I going to die? So we try to utilize this whiteboard where there will be, usually they use it for communication, like who's your doctor, who's your nurse, and that's it, not much. But we try to maximally use it, utilize it and say, these are the things that we're going to do for you in the morning rounds. At 9 a.m., I'm Dr. Sunil, and this is what we're going to do for you today. I'm going to get an ultrasound abdomen because the CT did not show much, but I highly suspect there might be some gallstones. Your kidney function creatinine is greater than 50% or 100% than what your baseline is. I think there is some kidney stone or something else going on with you. I think you're puking because you have a small bowel obstruction, and the CT scan final result was still waiting for it, but preliminary study from last night showed that. So, and I'm going to get a surgeon. And your anticipated date of discharge would be maybe in the next 48 hours. And no surgery planned. These are the labs that we're going to obtain from you. And then the patient's family come in the afternoon to visit them, and then they have 100 more questions. They cannot get hold of the nurses or doctors because they're really busy. They write it on the whiteboard, and I come back in the evening at 4 o'clock, and I answer those questions for the patient. Maybe the patient will not speak English. Maybe they need some translator, and they write it in Spanish or some other language that they wanted to answers for. And I try to use that and use a translator, get answers for them, and maybe the patient will understand now. Maybe the patient is an 80-year-old, 90-year-old demented patient, are very sick, not able to even ask questions. And the family wants to know everything. And I can use the whiteboard again. So a simple measure like that, using the whiteboard to the core, has really helped in real time to delineate many questions. And besides that, we have implemented hourly nurse leader rounding, utilization of patient experience leaders in the transitions of care, which means there will be 1 or 2 dedicated staff. They will follow the patient right from the ED through their inpatient stay and every day try to ask them questions. How was your stay? Do you need any help other than the medical? So this is more directed towards the non-medical and non-nurse, non-doctor related questions. My food is cold. Can you help me with this? I needed something. So right now, I needed to reach out to my family right now because they don't know where I'm at. And they're really worried about it. So those are the patient care advocates and the patient experience leaders. And targeting early discharges to home with hospitalist at home models. This is a very, very innovative and COVID time. This was implemented with big positive impact, where a patient who was requiring 6 liters of oxygen run down from being intubated during COVID time could go home early on 6 liters of oxygen with one of the medics from my hospital visiting them daily, and me, one of the doctors from my team, following them virtually every day till they're off of oxygen. How cool is that? That they get to home early without even, staying there till all the oxygen is off. And I needed 2 more days of IV ceftriaxone for certain condition. I send you home with IV line if you don't have any history of drug use or something else. And I send you a medic, a pharmacist. They complete the one-time dose of IV ceftriaxone at your home, and they report to me, and I just open up my app, see you virtually, and say, yeah, everything is good, but I needed maybe a CMP or BMP to check your kidney function, your potassium. We draw that. I'm anemic. I got 2 units of blood. I'm not sure if I'm going to bleed more, but we could not find anything on colonoscopy. We send you home. I'm really worried because my PCP's appointment is not until next week. I send you a medic home. I send you home early, and they draw the bloods every day till you see your primary care doctor. So that's the hospitalist at home model. It was definitely received with a great impact from everywhere in the health organizations across the years. I'm not sure. I need to find out if anybody else from other regions have actually tried this or have been implementing this. And another innovative project was Discharge Lounge, where I can go home today at 9 a.m., but my ride won't get here till 10 o'clock. I can walk. I don't have any other issues. I did not take any pain medication. I did not take any sleep medication this morning. I just need to get out of my room because I'm being bored, staying in my hospital bed for 3 days. I get you out to this Discharge Lounge with 10 beds, and one of the CNAs, like nursing aides, can assist you if you need to go to the bathroom. If you need to eat at 12 o'clock because your ride won't get till 1 o'clock, yes, we will supply you with some food. So this is more like, you get out of the patient room, and we could utilize that with a new patient. At the same time, you're not ready yet to be picked up by your family or something else. So this was also unanimously was accepted, and the community really liked it. So these are all the measures we are trying to implement to improve the patient quality and satisfaction scores. Mind you that it's not related to the safety, which is the leapfrog, but definitely it has also showed some impact on the leapfrog too. So finally, this is my final slide, I promise. Results from 2019 to 2022, we're seeing a slow decline in our patient satisfaction scores. And you could look at it, 2023, from 65.5% to 70.1%, especially the likelihood of recommending the hospital question. It went up tremendously. It's very hard to move this needle, especially for this question of likelihood of recommending, in spite of achieving even 99% on other questions, but we're able to achieve a significant growth of 12.8% now with the communication with the doctors and nurses as well. So utilizing the innovations from the COVID times that was, once, of course, everybody went through this trauma of COVID, and all of us have lost wonderful people, colleagues, friends, family members during COVID times. But some of the innovative ideas that were implemented during that time has definitely some positive impact And we could, if we try to utilize in the right direction, we could use them, streamline them, use them for other things as well, especially the patient satisfaction. So what are the recommendations? Use the whiteboards efficiently and effectively. Early DCF patients with less acuity to discharge launch if you could. And it doesn't need a lot of financial support. You could just do it by identifying a small room, or maybe a 2 patient rooms which are attached together, and then try to put 10 beds in. Nursing leaders hourly rounds, telehealth virtual hospitalist rounds, and as I explained very detailedly about hospitalist at home, it definitely helps in reducing the gaps between inpatient and PCP visits, so that it ensures that we have the safe and the continuity of care as it should be from inpatient to outpatient or any transitions of care. And establish and involve patient care team or patient experience team members. And it also showed a big impact, because sometimes, I don't care about your food, I care about the medications I give to you. No, I need to care about those two. Those little things can impact big if you're looking at your HCAHPS. I might do a good job as a doctor, but if my team member who's an environmental services or nutrition services colleague does not provide the same level of care or service to the patients, all the work and hard work that we did probably is going to be lost in the drain. And real-time patient nursing team communication to address trivial issues concerning concerns using the EMR apps. So many of the EMRs, electronic medical records, nowadays are using this real-time communication. The doctor is not paged anymore from the nurse. The nurse is not really looking to call directly on your pager or your cell phone at 2 a.m. She will just simply use the app, EMR app, send you a text, and you respond back. And then that's it. The issue is resolved, and your patient is safe. And you may ensure that the patient is taken care of. Thank you. Thanks for the opportunity. And again, apologize for not being there in person. I want to stop there and see if you have any questions.
Thanks a lot, Dr. Sanel, for this information you provided from your research. I have a question for you, that the survey at the beginning, is it applicable for similar hospitals to apply?
Yeah, so again, as I'm sharing here, so if I understand your question correctly, yes, we can definitely use this HCAHPS survey anywhere for any level of hospital. But when you try to do the star rating, the CMS automatically pulls the together, all the hospitals which are alike together in one pool. All the 130 bedded or 100 plus bed hospitals which belong to the rural community across the US is pulled into one category. And then if my hospital is 3-star rated, and they will only compare to the like-minded hospitals, which is like 130 bedded hospital, say in Tennessee or in Washington or somewhere. So to answer your question, yes, this survey is available online, and you can use it for any hospitals, any similar level hospitals across the world.
Great.
And this, yeah, and to just back up my point, this is not the best of the options, but this is the best of the options they could come up. Like never, sometimes, usually, always.
Okay,
yeah.
another question. What was the main purpose for this study?
Yeah. So we were actually apart from the communication being low, and we tried to implement and all these innovative measures after the COVID and during the COVID time. We were losing a lot of money, as well as financially we were getting impacted. And if you remember, across the world, some of the colleagues in the healthcare had to lose their jobs, like temporarily. And we're trying to see how we can work on this kind of things where we can retain our staff We can support our staff. Doesn't necessarily have to say in future, say who knows what happens in 2030. And we don't know when the next pandemic will hit us. So be prepared so that you can support yourself financially. And you don't have to really worry about like, hey, my hospital is not performing well. I'm going to lose this $15 million for next year from CMS. So instead of that, we tried to put this project in place where try to use the minimal things and work on it so that you don't have to lose anything. I know moral support or the CMS would be looking at, yeah, you did a good job, even though you're not the best, you're not comparable to the other hospitals, but utilizing minimal things, you did really good. So that was the main purpose and main idea, actually.
Yeah, thanks a lot, Dr. Sanel, for all this information. Is there any question for Dr. Sanel, please? Okay, thank you, Dr. Sanel. Your presentation was very clear and full of information with details. I like it so much. So, thank you for your presentation.
Thanks for the
And I would
opportunity.
like, you're welcome. And I would like to announce that this is the end of our conference today. And we are going to start our conference tomorrow, inshallah, at 1 p.m. Dubai time. So until tomorrow, be safe and see you tomorrow, everyone. Thank you for joining.